Great. Welcome everyone to the November meeting of the Universal Health Plan Governance Board. Apologies for the late start today. We had a number of traffic snafus. Let's get started with the roll call.
Helen Belanca.
Here.
Shenhui Chi is absent today. Amy Fellows.
Here.
Michelle Glass.
Here.
Bruce Goldberg is on leave. Judy Richardson.
Here.
Cheryl Ramirez is absent today. Mary Lou Henrich.
Here.
Thank you. Michael Leahy.
Fully present.
Thank you,
That's
everyone.
Great.
Thank you, Cole.
We have a packed agenda today, so we will try and stay on time and cover all of the topics we need to cover and have some time for discussion at the end. After our executive director report, that will include a review of the OHA federal authorities report. We have our annual report to the legislature that needs to be approved today. And then we have pretty robust committee report outs with multiple straw proposals for us to consider. And we are leaving the finance and revenue discussion for the end. We're going to try and save plenty of time to review their revised proposals. So it's a lot to cover today. Before we get started, I'll briefly summarize the public testimony that we received this month. There was, again, a lot of public testimony, which we really appreciate. We're always glad when people of the public take the time to write into us about their concerns. We had 10 people write in just to express general support for our work. We had 4 people writing in to specifically ask for more union engagement. And one of those pieces of written testimony had 214 signatures on it. They were requesting 1 or 2 public engagement sessions specifically with unions. Regarding that topic, I wonder if I can ask Michelle and Amy as chairs of our community engagement and communications team, if you would consider taking a look at some of that testimony and discussing this within your committee about union engagement, and then possibly coming back to the board in December with a recommendation regarding union engagement. I know that public engagement is really in your wheelhouse and you're just getting started in that work. Would you be willing and able to think about that and come back to the board with some discussion or proposals?
Thank you, Chair Belanca. This is something that has been a theme of public testimony, I think, last month and this month. So it is something that is under discussion with Diana Bianco and the CECC. Thanks. We're happy to report back at a future date.
Great, thank you, appreciate it. Melissa Cliver wrote to express some concern that any government-controlled healthcare may eliminate access to some services, and asked us to clarify who would make policy for the universal health plan coverage. She also encouraged us to use plain language and consider a pilot of the UHP. As a reminder, the UHP would be governed by an independent nonprofit public corporation and not by a state agency. Leon Boat wrote to request that personal support and home care services be offered in the universal health plan without regard to income, so that people who are living with disabilities can continue to work. Stephen Kemble is a physician in Hawaii, and he chairs the policy committees for both one-payer states and Physicians for a National Health Program, and he offered his consultation for our work. Charlie Swanson submitted testimony and included data on the effect of induced utilization and in-migration on total health expenditures in a state due to Medicaid expansion in a nearby state. Richard Gibson wrote to review some of the factors leading to high healthcare costs, including hospital consolidations and mergers, pharmacy benefit managers, new expensive therapies, and high labor costs, and offer his thoughts on UHP impact on those, encouraging us to deal with some of them now. Appreciate that. Robin Gottlieb wrote to say that higher income earners, which they defined as anyone over $200,000, should pay a higher percentage of tax to the UHP. That proposal had 217 co-signers. Dan Keeley wrote to encourage us to pay for a limited set of benefits and expand as we are able. Tom Sinsick wrote to say that we should develop a plan exactly as outlined in the legislation and not approach it in an incremental way. And Vern Sabo wrote to request that healthcare providers be paid based on quality and performance and not type of provider. So again, thank you to everyone who took the time to write in. We read everything. We take it seriously and we appreciate you doing that. Next on our agenda is to approve the minutes from our October meeting. Is there a motion to approve those minutes? I move that we approve them.
Second,
Any discussion?
I had a couple of picky and wording things. I could probably just give that to Isabel later. They're not substantive.
They're not substantive. Okay, yeah, as long as they're not substantive, then I would just give that feedback to Steve. Thank you. Anyone else with discussion? Okay, we can do a roll call vote.
Helen Belanca,
Yes?
Shenhui Chi is absent, Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Joe Ramirez is absent, Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
That's everyone. Thank you.
Great, thank you. Do we have public comment on voting topics today?
Yes.
Okay,
Yes, so, as always, we're very appreciative of members of the public providing comment. There are a number of things that the board is voting on today, and we have, I need to do a little bit of thinking because there's some people signed up that aren't here yet. But first, we will have Tom share in just a second. Tom, you should be able to unmute and share your public comment now.
so as a reminder to folks giving public comment, this time frame we reserve for your input on things that we will be voting on today. So if it's not related to something that we're voting on, please save it to the end of our meeting or submit some written comments. But any of the things on the agenda that we'll be voting on. Go ahead, Tom.
Okay, just thank you for mentioning my testimony. It's at writing. I am speaking, Tom Sinsick. I am speaking as one of the authors who created the Universal Health Plan Governance Board and with Oregon's constitutional obligation in mind. I am very versed in the ORS 751, so I'd like to please ask that you make sure all your materials reflect ORS 751 and replace that with a statutory reference. It's no longer legislative, it's statutory. So there are many places where it would be way appropriate to replace language with 751. I submitted my testimony and it is, again, focusing on in your plan, everything that you submit, that it's completely in alignment. If there are members of the governance board who are tempted to think of approaching this in an incremental fashion, we're asking you all to resist that temptation and fully understand your charge. The other thing I want to speak about is the value-based payments item for primary care. As a 35-year deliverer of primary care, nurse practitioner, in my training, it was never the idea that you're going to do this for some extrinsic reward. Extrinsic rewards are for toddlers. That's how you start out training them. For people that are doing clinical work, the reward is intrinsic. So there is a big issue of the cost related to value-based, and I'm going to read some commentary that was submitted to me by somebody that knows this work. As an addition to basic costs, so it's very costly to do this work, expenses reimbursement has some effects. It muddles cost transparency. The changes it induces are short-lived, can disadvantage providers who take on complex or specialized populations, and it can disadvantage primary care doctors as well. It is possible many years of decades from now that it will work as intended, decades. Plus, the way it has been rolled out, it can mean anything from quality bonus to hitting a measured target to simply a capitated per member month and reporting the percent of enrolled population. It's easily gamed. If a provider isn't doing well on those metrics, they're going to get punished and their ability to improve and continue to deliver care is going to go down. So please let go of the idea of value-based payments. It's an affront to those people providing primary care. Thank you very much.
Thanks, Tom. How many others are there, Isabel?
There were a total of 3 signed up. I'm not sure if everyone's here.
Yeah, Richard, I had you signed up if you'd like to.
At the end of the meeting.
Okay,
Thank you.
and then we have Claire Holm.
Great, thank you. Can you hear me okay from here? Okay.
I just wanted to read a bit of the testimony submitted by Robin Gottlieb ahead of the vote on the straw proposal for the finance and revenue vote. It has to do with wealth inequality. Wealth inequality in Oregon is extreme. As of 2022, the top 10% of Oregonians own 75% of all the wealth in the state. The income of the top 1% has risen 345% since the 80s, while the average income of the middle class has increased only by 15%. In order to maintain a principle of equity, we, 217 signatures, believe that higher income earners should pay a higher percentage of their income than the middle and working class to fund this plan, because they can afford to do so. There may be a concern that wealthy people will leave the state if their taxes increase, but that is a myth, and there is numerous studies to this effect. I listed the studies in the testimony. Feel free to check those out. We have a local precedent in Multnomah County where we implemented a universal preschool program funded by small tax top earners. Moving on. This board has an extraordinary opportunity to make history and improve millions of lives by establishing Oregon as the first state in the nation to guarantee healthcare for all. The working and middle class hold the greatest voting power in Oregon, and the success of this plan depends on the earning their confidence and support. This will only happen if the wealthy pay their fair share. Thank you.
Thank you. Appreciate that. Okay, we will move to the executive director report. Go ahead, Mimi.
All right. Lou has raised his hand. Did he sign up for testimony at the end? Okay, great. All right, well, pardon?
Maybe those.
Oh, okay, okay, great. All right, well, good morning, everyone. I'm Mimi
Oh, I'm
McCollum.
sorry. Lou, did you intend to give comment on voting topics?
He's on.
Lou, we see your hand. Are you raising it because your intention was to give input on a voting topic?
Yes.
Thank you. I had you signed up for the end, but. we can-
Okay.
we can
No,
switch
no,
it.
I wanted to talk.
Which agenda item were you speaking on
Yes,
behalf of?
yes, I have comments on administrative structure and also the revenue plan.
Okay, go ahead.
Thank you. Jesus. All right, on the administrative structure, I'm afraid that this is going to create an unnecessary bureaucracy that will cost more, especially when I heard about that it would be brick and mortar places throughout. All right. I asked the board to please consider the added costs that this would make. On the revenue plan, and I'm speaking for myself, even though I've been a supporter of universal care for years now. I agree that it allows the super rich, and I would say $400,000 or more, to not pay their fair share. If you base this on a percentage basis, they should be paying the same percentage as everyone else. The middle class, the working class, are tired of carrying the weight for the rich and the poor. I think you should consider the federal poverty level. Why not allow them to pay the same as everyone else? Again, the working class is tired of carrying the poor. Also, what's before you is charging more for dependents. The more dependents you have, the more it's going to cost. This represents, that's like saying the more you use the system, the more you're going to have to pay, which is a reflection of the insurance industry that we're having today. And the last thing I want to say, I think you should consider a flat tax. Everybody pays the same. Thank you.
Thank you, Lou. Okay, go ahead, Mimi.
All right, well, thank you again. Good morning. This is Mimi McDonald. I'm the Executive Director of the Universal Health Plan Governance Board. And so I want to keep it brief today because I know we have a very packed agenda, just a couple of announcements. One is that Sean O'Day, who has been the acting director of DCBS, was sworn in yesterday as the director of DCBS, which is the organization that UHPGB is under, and I'm delighted to have that happen. That was a great event. The next thing that I wanted to share, if people have not had the opportunity to look at this, the Office of Economic Analysis presented it to December Economic and Revenue Forecast to the Legislative Committee on Wednesday of this week. And I have some encouraging news to share. And this can be, you can look this up on the website, but and this is I'm reading this from Betsy, we have to make sure that I get her last name correct. Betsy Imholt, who is the director from DAS, one of the directors of DAS. I will say the economic outlook reflects continued economic resilience, both nationally and here in Oregon. Encouragingly, recession risks appear to be easing. The projected general fund ending balance has improved from a deficit of 372.7 million, so 372.7 million, to a deficit of 63.1 million from last quarter. So encouraging. And while the projected deficit is reduced, the state budget still remains out of balance. The 63.1 million projected general fund deficit does not account for unanticipated costs due to federal implementation of HR1 and continued need for essential state services. So just wanted to share that information with everyone before we talk about budget, which is, we'll go to the next slide. All right. Thank you, Isabel. So what I wanted to share, we haven't had an opportunity, and I'm not going to go into too much detail, but to go over what is the legislatively approved budget for the biennium for the Universal Health Plan Governance Board. And if you look on the first column, it says working biennial budget. At the very bottom, the expenditure total that we have allocated is essentially 1.8 million. So that's for our biennium. What you'll see, personnel services, that is for your employees of the Universal Health Plan Governance Board, services and supplies, that number is mostly taken up by our consultant work. If we go over to the next column, and now this is just as of September 2025, so not today's date, you'll see what the actuals are to date. And then we have for the actuals and planned for the biennium. So that's that column, that's the third column. And then the fourth column, which you'll look at, is over or under. So what we are projected to have, and this is as the budget is written as it is that we will be under budget of that 1.8 million by roughly $144,000. So if we go on to the next slide, or actually I'll stop there and see if there's any questions.
I'll have some comments but I'd like to get you, and I see the whole presentation.
Okay, well, there's not too much, but I
Yeah.
wanted to go on to the next one, which is our professional services groups and our contracts. And so again, these are the contracts that we have. Now, some of these contracts span the biennium. So both bienniums rather, so it may be a little bit confusing. So the actuals to date, for example, in Echo Northwest includes dollars that were spent in the last biennium. All right. So, but what it is correct is their total budget is correct. And so what you can see is that we're coming close to the end of our budget for Echo Northwest. And you can see where we are at with Milliman, where we are at with Patty Wentz, that's under Wentz Jackson. Artemis is Diana Bianco. OCIN is our interpreter service, and also Perfect has been our translation service. OCIN is taking over our translation service as from I think from this month on. Yes, sorry, I was looking at Isabel. So I'll stop there, see if there's any questions.
Don't have a question. I thank you. This is really helpful to know, because I've been wondering what it was that we actually had budgeted for the consultants for Milliman and Echo Northwest. I guess, being on the Finance and Revenue Committee, I am wondering whether, we have enough left, for what we need from Echo Northwest or not. I can't speak as the chair and Cheryl isn't here. But, you know, if there's 43,000 left, you know, is that gonna get us the amount of consulting we need over the next couple of months to get us a real straw proposal? Because I was concerned today that this looks like we're gonna have a straw proposal. We really don't have a straw proposal. We have a couple components that we're gonna talk about, but if you read the November 14th Echo Northwest report, which is the day after we had our finance meeting, there really isn't, as I understand it. Richard, Richard was on that committee too. I understood we were not gonna have a real straw proposal. We were gonna have like 4 components that we were going to talk about. Medicare, you know, so either I missed it, but I don't see a straw proposal in here.
Well, so if I can just say, so there's sort of, I think, 2 parts to your question. One is, will Echo Northwest be able to complete their contract with the funds that they have? They're very well aware of their balance. I just had a conversation with Morgan, and they certainly are going to complete what they have from the deliverables from their contract.
Okay.
So from that standpoint, I think that we are good there. And then maybe we can talk about the revenue during the revenue discussion instead of, if that's okay, the
What
straw proposal
Oh, yeah,
during the
Yeah.
time that when we discuss.
Then there's a report out.
okay, yeah.
If that's okay.
That's fine.
Okay,
But that, and then the other piece that the fact that at the bottom line with you, way you project now, I've done lots of budgets, so I understand this. But there is over $100,000 that is projected that hasn't been committed yet.
correct.
To something. Okay, so that as we talk about what else do we need or what do we want to do, there is at least a little bit.
Correct.
You know, 100,000 isn't a lot, 2 years, all that I understand, but there is just at least a little bit. So
Mhm.
that feels better than kind of not knowing. So I appreciate this very much.
Excellent. All right, any other questions? Okay, I think, for the OHA, yep, you can go on to the next one, next slide, thank you. The OHA Federal Authorities Report. I wasn't going to do a report out, we had a presentation at the last meeting. I just wanted to draw people's attention to the fact that that is now posted, their final report. And I think, I haven't looked to see if Jessica is online, if people have had a chance to look at it, if they had any questions. Jessica Marino was going to be online to answer any questions if there were any. Oh, and I see her. So,
I haven't seen that final one. I heard I was here last month when there was the report. I was just concerned about the date. That was the presentation. Is this the same thing as we had last month?
yes, so this is, a presentation was given
Yes.
on OHA's deliverable
Yes.
discussing,
And they said that they would have their final report by December.
yep, it's
Is
this, so
that
the
this?
final report is posted, yes.
Okay, and I don't know when that posted. I missed that, so.
There were a lot of things posted. I don't blame.
Yes,
Thank you.
and I was trying my best, but that one, the only thing that she talked about last month that I had a concern about was kind of saying that things wouldn't be ready till 2032. And I don't know if that number is still in there or not.
Diagram.
And I just have some concerns about that I think needs to be. I'd like to have that discussion from the board and how do we move that?
Yeah,
forward.
absolutely, sort
That
of the
it's
discussion about
2028 or something, but not
authorities.
2032. It just felt too long to me.
Yeah, I'll
That's all.
pass that to Chair Blanca.
Jessica, thank you so much for joining us. Can you just do a brief recap, refresher about the federal waiver process and the projection that that would be, the time that would take would get us to about 2032?
Yeah, absolutely. Hi, thanks everyone for having me. I'm Jessica Marino, policy analyst with the Oregon Health Authority. And yeah, just as a reminder, at the last board meeting, my colleague Laurel Swerdlope gave a presentation of kind of the framework of this deliverable, this federal authorities report. Federal authorities that OHA believes would be required in order to implement the plan as proposed by the Joint Task Force. And then we shared a draft of the report. So it's about a 24-page report that was included in the meeting materials for today. And I believe Mimi can speak to the deadline that she has set for you all to provide feedback, and I'm just here today in case anyone did get a chance to take a look at that draft and wanted to talk about any questions that came out of it. In terms of the timeline piece, so during the last board meeting, some slides were shared that included a visual of the timeline. So you can take a look at those if you would like a visual. But yeah, so our process for kind of applying for waivers, specifically the 1115 Medicaid waiver, is a long, deep, engaging process that takes many years. And as a result, our current 1115 waiver timeline ends in 2027. So the next one, the earliest we could kind of start our work on that is it's really happening now. The conversations with CMS, the proposals, the analysis for our next waiver is happening now, and so the process for the next one would be in several years, which would lead us to 2032 being the earliest time that an 1115 waiver that incorporates some of the financing and design components that that the task force has proposed could start.
Jessica, is it accurate to say that when you request federal waivers, generally generally they are for a 5-year time period?
For the 1115 waiver, yes, that is correct.
Right, and so as you said, the current waiver is sort of due to expire in 2027, and so then a natural transition would be 2032.
That's correct.
Go
And
ahead,
it's because the work for the next waiver is already happening now, the public comment, all the analysis, it's a lot of work that leads up to the start date.
Great. Mike, go ahead.
So first of all, I have read the report and I wanna thank, I think it's an excellent report, so I'm quite impressed with it. Having said that, and having been part of other processes, there usually are ways to streamline the timeframes. Now, I'm very cautious about saying this because this interactions with the CMS is gonna be anticipated to be very challenging. But that said, I guess I'm asking a question similar to Mary Lou's, and that is, while the report seems fine, I think our board should be as aggressive as possible in terms of, if it's possible, for instance, to get something that might be a year earlier, we should do that. And I say that because I really feel that right now, things are getting incredibly costly. People are getting insurance bills in the mail. I mean, there's really an urgency to do all this. And while I appreciate bureaucracies and I've worked within bureaucracies, there often is sometimes other innovations if people are a little bit more assertive and aggressive with that. So I'm just suggesting that next year we're going to be getting into transition planning and the like. There may be ways to expedite some of this stuff, or there might be new pilot legislation, other things that this excellent document doesn't really consider.
Thanks, Mike. Go ahead, Amy.
I just remember last time I had asked about the K-plan waivers, and I want to make sure that it sounded like you all were doing more work into that, and I want to make sure we don't leave out the population of families with disabled children that are able to access OHP and in-home supports, as well as adults with disabilities that access those services.
Yeah, thanks, Amy. So the K plan is mentioned in the report. I will say that, we heard your comments, so we wanted to make sure it was explicitly named. A deep dive into the K plan, kind of, would be out of scope of this deliverable. The reason being there's no federal authority needed to keep the K plan or any approved state plan amendment in Oregon state plan. All of Oregon's existing approved state plans, according to our analysis, are really codified into Oregon State Medicaid plan and therefore would remain in place in a universal health plan that includes Oregon's Medicaid program. But the K plan is explicitly mentioned in that context.
Including Bill 1557, which was psych under 21, that OHA's Child Behavioral Health Services has been doing analysis about how to implement.
Can you repeat the name and number of that?
Bill 1557 that Senator Gelser Blowen championed, I believe, 2 years ago. And it's the psych under 21 portion of the K plan that Oregon never implemented. And so it's a new thing, but it is by statute something Oregon is supposed to be doing.
Mm-hmm.
To
I'm
cover
not as familiar with the
under
details.
21 with severe mental health crisis to get a similar level of support as the K plan offers disabled children.
Sure.
I can send you information about it offline.
Okay, that sounds great. I am not as familiar off the top of my head and want to make sure I have the correct information before I respond.
Any other questions for Jessica? Mike, did you have another question or is that from?
Oh, that's,
Okay.
that's from
I have a
before.
comment.
Okay.
I know that Bruce Goldberg is on leave at the moment, but hopefully we'll be back before the end of our work. And that, you know, his former role as OHA director, I guess I'm back to some of the stuff that Mike said. I'm hoping that maybe Bruce can help us too,
Mhm.
in terms of possible ways to move forward before the 32 date and to make sure that the next iteration supports the idea of what we're talking about here so that we don't have ourselves going forward with a 5-year plan that we're kind of going, oh dear, it really does not dovetail into what we're trying to do long-term. So anyway,
Right.
that's all. I'm just,
So I would just say that Judy and I and Mimi and Lee have had multiple discussions about this issue of timeline. And certainly the information we got from OHA about the process for federal waivers was a big part of that, as well as working with our consultants on their revenue projections. The question they have for us is, what year are we projecting to? What do you think is the start year? And so we've had a number of discussions about that. What we kind of came up with was that it did make more sense for us to focus on a projection year of 2032. And the reasoning is that the waivers don't have to be granted in order for us to start the work. You know, we've had several waivers in Oregon before for the Oregon Health Plan and for CCOs and for many other things. And the work is underway at the same time that the waivers are being pursued. And so it's not like a sequential thing where we have to wait for that. But we thought that, you know, our final report is due September 2026 for consideration by the legislature in the 2027 session. What we will need to be proposing in there what the final plan will look like, as well as a transition plan. We'll need to be able to explain in that final report how we get from where we are now to this universal health plan. And we need to offer them some sort of steps of that transition of how that would happen. There are enormous things that would need to happen for this plan to come into place. We need to create and establish a public corporation and seat a board. We need to transition all the hospitals to global budgets. We need to define a universal fee schedule and figure out provider payments for specialists, for primary care providers, you know, across the board. We need to secure a vendor to process all the claims because all the insurance comes through. There is an enormous amount of work that needs to happen in order to implement a universal health plan. And when we were talking about, is it more realistic to have that transition plan be in 2 years, so implementation in 2030, or in 4 years, 2032? It just felt more realistic that a 4-year transition plan made sense. So what our final report would say is we are asking the legislature to implement the universal health plan in 2028. But the first steps is going to be a 4-year transition plan of establishing all of the things that are required to administer this plan. And then everybody will be on board. We need eligibility criteria. We need an eligibility system. It's so much work, right? And so, but if they start work on the UHP in 2028, which is that immediacy piece, like this is important, we've got to do this now. We know we need to start making these changes in 2028, then reasonably by 2032, we could expect everything to be in place and things to be enrolled. So that felt
helps.
right to us. But I want to offer that up to the board to see if anyone has thoughts or comments. Do you agree with that? Not agree with that?
I have to be very careful here because I don't want to get sucked into having to do all this work myself, but,
Mike, you may have to project a little bit more.
well, with that as a caveat, I don't disagree with any of that logic. But if in fact one does an implementation over a 3-year period, I could at least make an alternative case for 2031. And I need to do a lot more research before suggesting that that makes more sense than 2032. So I clearly understand that perspective, but I also know if you don't push things and if you're not aggressive, things laggard and the can gets kicked down the road. So I would just suggest that 2031 also be considered.
Yeah, I agree with you that being assertive about what we're asking is key, but we'd be asking them to start in 2028. That all of these processes need to kick off in 2028 immediately after the session. So I think that is pretty assertive.
Yes.
Right. Any other thoughts or questions? Judy.
Thank you, Chair. Yes, I agree with the points that the chair has raised. In addition, remember that we're not just thinking about designing something ourselves. We have an ask for the health system in the state of Oregon to transform with us, which is monumental. So think about those clinics that already have existing contracts. They're going to have to change structure. They're going to have to come along with this law. There's that element too. We can design a plan and push it out for whatever timeline we think we can control, but asking the state to come along with us is an even greater lift. So remember that piece as well.
This will change everything about how every healthcare institution and clinic operates. And so that's no small feat. So, yes. Is there a hand?
Jessica has her hand up.
Okay, yes, go ahead, Jessica.
Yeah, thank you. Thanks, Judy and Helen, for reminding us of the Herculean effort that we're talking about here. And kind of to your point about, we're talking about when we're aligning with OHA's and CMS's timelines for 1115 waivers, it's really 2032 or 2028. And if we were to kind of explore this 2028 possibility, the reality is, and we talk about this in the report, is that the current federal administration has announced that they do not intend to approve any new state proposals or extend existing 1115 waivers. So that's something that's really, really critical to keep in mind. It's a collaboration with the current CMS and federal administration, who is at the moment not supportive of 1115 waivers. So that's a big reason why 2032 feels more feasible.
Thanks, Jessica. Any other thoughts, questions on this? We weren't certain, honestly, if this is something that the board wanted to sort of vote on, but I just want to offer to anybody if you have concerns about this and, that we could continue discussing, but.
It seems much too soon to
Yeah.
vote to me,
Well,
for like to vote today. That's what you're suggesting.
okay, so we're asking our consultants, which have a limited time to give us some projections to where they should focus their projections. So
Oh, okay.
there is some pressing.
Okay. I just didn't see a vote on this section. So.
No, there isn't. And there isn't a vote on this section because we didn't feel like it was necessary. We felt like it just sort of lined up that between the waivers and the transition plan that will need to be in place, that a 2032 deadline made sense. So we didn't put this for a vote, and that's why. But if board members have concerns about this and want to continue discussing it, we can add it to our December meeting and kind of keep it on the agenda. Otherwise, we would just go with 2032.
I guess I would propose that we have it on the agenda, think a little bit more about it and consider the things you were talking about, consider that we've been talking from the financial thing of like 2030. to make the projections. I mean, so
Right.
we've kind of got these different years that we've all been kind of thinking, and I think maybe we need to get ourselves in sync.
Right.
And then also, you know, I like Mike have worked in bureaucracies and I know how things go, and I have not done the federal thing, okay? I know Bruce has. And so, you know, I'm also kind of like, yes, there are ways. Things are very disruptive right at the moment. I understand that at the federal level, and, you know, we don't know exactly what's gonna be happening and when. So just, I guess my message is to push forward as much as we can, and
Yeah.
it sounds like that's what you're talking about.
So Jessica, I just want one more time to clarify. You're saying that it is not possible for Oregon to have federal money from Medicaid, Medicare, or the ACA subsidies, whatever's left of them, by 2030. That the soonest we could get those are either 2028, which isn't feasible, or 2030. Is that accurate?
2032.
2032.
2032, sorry, 2028 or 2032, that it wouldn't be possible for those waivers to be approved by 2030. Is that accurate?
When we're talking about the 1115 waiver, historically, we've always followed this 5-year timeline, and it would be unprecedented to use another timeline. And I think it would be difficult to like say yes to your question without having conversations with CMS as well. It's not solely up to me or to OHA.
Right. Right, but the standard or the precedent is 5-year cycles, and so that would put us at 2032.
Exactly.
Yeah, okay. All right, we will keep it on the agenda and bring it up again in December and have some more time for a discussion of that. Great, so let's move on. I have a couple of quick updates. As you all know, our annual report is due to the legislature December 1st. We are so grateful for the board's feedback and input on that report. And I want to say a special thank you to our staff who have done an incredible job of summarizing our work and writing that up. I think they came up with a great product. We've reviewed all your feedback. We've incorporated, we've reconciled the feedback with the work that we've done. Our task today is to approve our final report for submission to the legislature. Is there a motion to approve our annual report?
So move.
Michelle has her hand up.
Michelle?
Are we going to do discussion after we have a second?
Yes.
Okay, I second. And then I have
Okay.
discussion.
Okay, go ahead. Go ahead for discussion.
Thank you. Thank you for, yeah, I want to echo the appreciation. The report looks really great. And I also want to thank Chair Belenka, Vice Chair Richardson, and our Executive Director, Mimi, for representing us so well in the verbal report out to the legislature on Tuesday. I got a chance to watch it yesterday, and we were very well represented. Thank you so much for doing that engagement work with the legislature. My only comment at this time is to ask if this report that has the board feedback in it has gone to Patty yet for review.
Communications consultant.
I know Betty is, yeah. I'm not aware. I don't think so, but has it? No, we were.
Okay.
No.
So my request to the board. Sorry, my request to the board is to provisionally approve it today with the understanding that it will go to our communications consultant per our process before submission, and then empowering the executive director, the chair, and the vice chair of the board to finalize and incorporate any feedback from Patty before submission. This is one of our first opportunities to follow our process, and this is one of our most important public-facing documents representing our work, and I think it's really important that it go through that part of the process. So that's my proposal or request to the board, that we provisionally approve it today with the understanding that we will follow our process, and it won't have time to come back to us. So we're empowering the executive director and board leadership to incorporate any feedback that our consultant may have.
Yeah, that sounds okay. Mimi, do you have I'm not sure what the timeline is for the submitting. Do you have time to communicate with Patty about it and get that? Okay.
Yes, I
Okay,
believe we can.
great. Thank you, Michelle. Yes, any other discussion?
I hate to be doing this late, but I have been pondering it and thinking about it, and I have a couple of simple kinds of things, I think, where there is not consistency always talking about preliminary recommendations. Some of it says, so I'm just concerned that our straw proposals are pretty preliminary as I see it. They're in kind of softer cement or something, but they aren't final ones. And so several places, and I did write down and can give
Okay,
you
thank you.
where, it might say eligibility on page 6, preliminary recommendation, because you have it in some places. but
Okay,
not
just
in some
consistency.
kind of
Thank
thing.
you,
So I
thank
can
you.
give you
Yep.
that. My really kind of substantive one, and Helen, I texted her very late last night and wrote her an email, and I'm really sorry that I'm late, but it is what it is. I am concerned about using the word stepping stones. I suggest something like just other possible policy opportunities versus the idea that we do have to have stepping stones, and there may be, but it's just, I don't know, I just don't like that wording. And I offer just kind of, saying other possible policy opportunities is the heading kind of thing. And then working a little bit on those 2 paragraphs that lead into it. And the one, I'm fine with all of those policy options, with the exception of the public PEB plan. This was an issue that actually I was quite involved with back when Andrea Salinas was still here and had her work on this, etc. And there are real issues. I mean, maybe a public plan of this nature for partial stuff might have been a good idea 4 or 5 years ago. But I'm afraid that it is not helpful. It's also confusing in here, the way it's written, because we're talking about businesses and putting the PEB plan. Well, the PEB does self-insure, but it uses MODA, Providence, and Kaiser as options. So I'm not sure how to put those on the marketplace. I'm just not sure that I agree this is, and we really didn't have on any of these, but especially on this one, we haven't had board discussion. And watching various legislative presentations, and you guys, Judy and Helen, did a great job the other day. But you also saw the limited amount of time that you have. And so it may be that others would kind of delve into some of these things in more depth. And since we haven't really had those kind of vetting and discussions about them, and especially that one was a very complicated and politically divisive thing when it went on, with some of the advocacy groups that usually are together fighting each other. And so I just hate to kind of have that one raised in, and I would like
So-
it taken out.
So thanks, Mary Lou. We talked about it to a limited extent at last meeting, and we agreed that because the nature of our work is enormous and there's a lot to get through, that we would provide all of that information to the board a month ago, which we did, and request feedback by October 31st. And so we've taken all the feedback and we've heard your concerns. We've heard from many people on the board about it, and most people are okay with it. So we do appreciate that. And we appreciate your sort of comments about it. So I'm concerned about lack of time. We have to get this submitted. And I'm concerned about making so many changes and then the board not being able to see the final version before it gets submitted. So we have general agreement on the report as it is. The board can make a decision that we can incorporate the feedback of Patty Wentz, certainly. We can incorporate some of Mary Lou's feedback, and then this board can authorize me and Judy and Mimi to just make a call on what we include or not. We don't have time to do a revision and then get it out to the board and then get it back before the Thanksgiving holiday, and then the report's due the Monday after the Thanksgiving holiday. So the time is very, very short. And so we have two options. One, you can authorize Judy and Mimi and I to sort of incorporate any changes that we feel appropriate. Or we can just submit the report as is and have a chance to have everyone vote on it. And I would, again, remind people that most people have agreed with the report as is.
Can we see like how people voted when, like we were,
It wasn't an official vote. We just encourage people to give us feedback. We're not allowed to vote by mail because it's
Yes,
not a public process. So we just encourage people to consolidate their feedback to the staff. Judy, go ahead.
Thank you, Chair. Just a point of order. There is a motion and a second on the table. To your discretion, after discussion, we should still vote.
Yes. Yeah.
What did you say, Judy?
So there's a motion and a second on the table and we're having a discussion. So we could just call the vote if we wanted, unless anyone else has a further discussion.
Well, I have a little bit more. If you're going to have you and leave that piece in, which I highly say I don't like it, but okay, I'm just one member of this board. Your footnote number 19, if you go to it, you comes up to a page that says this page does not exist.
Thank you.
So you might not want to have a footnote that goes to nowhere.
Okay,
Very, very simple point. Can somebody read the motion? Because we've had a lot of dialogue
Right.
since, and I'd like us all to be clear on what the motion is.
and I would like, I have another comment.
the motion is to approve the annual report as written and included in the board materials to submit to the legislature. That's been the motion that was proposed and seconded. And then Michelle requested that we add a caveat to it, that we submit the report to Patty Wentz and incorporate her feedback. So I would amend the motion to say, the motion would be to submit this annual report to the legislature with recommendations included from Patty regarding the wording and language of the report.
And I have a comment.
Okay, go ahead.
In the future, if we are asked to send back our thoughts, I would like more transparency to see how people responded.
We're not able to do that because of public meetings law.
Well, at the next board meeting, we could share that. Or I don't know.
Do you mean, okay, yes, so.
On what, on these options that we were asked
Okay.
about what should be included.
Okay,
I'd like more transparency if we do something like that in the future.
okay. So we've had a motion and a
I don't know
second,
how anyone else feels
Mhm.
about any of it,
right?
and we haven't had enough discussion.
Just procedural. Do I need to stop my original motion, or, because you've just amended it, but you amended it halfway, and then there was another motion for
Okay,
you and
so the
Mimi
motion,
and Judy.
will somebody like to propose a motion that we submit the annual report to the legislature and incorporate Patty Wentz's feedback? Let's just leave it, the motion as that. Is there a motion to incorporate Patty Wentz's feedback to what's currently there and submit it as is? No.
Judy has her hand up.
Chair, I move.
Judy,
So moved.
okay, is there a second?
Second,
Michelle seconded. We've had discussion on this. If, does anyone have any final words to say, or we'll take a vote on this, and then you can vote whether or not you think we should do that, and if not, propose a different motion. Go ahead, Mike.
Well, I actually thought there was a motion that included Patty, but also included you and Judy and Mimi incorporating things, and I would be more comfortable if you included that, because I think there's some wisdom in considering what Mary Lou says. I mean, there's positives of just doing Patty Wentz thing, but I think the substantive thing is we need a decision-making about
Right.
using common sense, and I applaud you guys writing this stuff. However, I've privately told Mimi, I think a lot of excellent report, but these stepping stone things
Okay.
are not to me as vital as they possibly could be. So
Okay,
that's
so
why I'm-
you're right, we need to separate that out. Okay, so we're gonna separate that out and you're right, I'll clarify. The motion on the table that has been proposed and seconded is that the annual report submitted as is with the Patty Wentz, with feedback from Patty Wentz incorporated, and that the board is leaving the decision about the incorporating Patty Wentz to me and Mimi and Judy. That's what's on the table. If you prefer something else than that, then you can vote against this and we can have a different motion. But that's the motion that's on the table. The report as is with Judy and Mimi and I incorporating Patty Wentz's feedback. So it's been proposed and seconded, and let's have a roll call vote on that.
Helen Belanca,
Yes.
Jen Wickie is absent, Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Joe Ramirez is absent, Mary Lou Henrich,
No,
Michael Leahy,
Yes.
thank you.
Okay. Thank you. So that passes. Okay. And again, as always, I'm happy to have more discussions offline about those aspects of the report if you have concerns. Okay. So the rest of my update is Michelle and a few others have already alluded to it. Tuesday, Judy and Mimi and I presented a report to the Senate Healthcare Committee at their request, which went really well. Afterwards, we had a meeting with Senator Manning, who's one of the co-sponsors of the legislation that created this board, and that went really well. And we have an update with Representative Nose, who's the chair of the House Healthcare Committee in December. So we'll be meeting with him. We've reached out to Representative Nelson's office as well. He's the other co-sponsor of the legislation. So we are making the rounds in the legislature in advance of our annual report being submitted. So that folks know what we're up to. So that's been going really well.
I would just like to say I watched it live yesterday and you all did an excellent job.
Oh, thank you. Thank you.
and I was there and it was instant.
Great. So at this point, let's move on. We're a little behind schedule, so I'm gonna pass it to Judy for an operations committee report out.
Thank you, Chair Belanca. So we last met in operations on September 25th, where we discussed the administrative structure. We'll see a straw proposal for that in a minute. Just to remind the board of the work we've completed, we've had a straw proposal on public trust, so the regional entities follows logically after that. Our next meeting will be tomorrow, in which we'll be discussing operational models for integrated primary care and behavioral health, eligibility and enrollment, and start talking about the transition committee planning. The straw proposal, I believe, is next, and with Lee's assistance, we'll take a look at that. The straw proposal delineates the central and regional functions. Lee, would you like to present the nuts and bolts of the straw proposal?
What does that mean? Sure. All right, yeah, let's dive right in. As mentioned, the committee has considered this for a while and very excited to present it. So our guiding framework here, these are all things that should be familiar to boards. I believe the board saw this, but just noting various levels of involvement, finding that sweet spot somewhere between accountable and advisory, noting that the region should not bear financial risk. We want non-overlapping regions and of course, concern about regions retaining profit. This really formed the basis of how we wanted to build this administrative structure. So some of the different structure functions and plans, noting that of course this is going to be under the public corporation proposal, really building off that previous operations proposal there. But that the central public corporation would be responsible for things such as the financing, policy, payment systems, designing those benefits, the overall quality strategy, and doing things such as the data collection and analysis, working with an administrative services that would handle all of that claims management. Public corporation and regional would then be doing those really more local functions, things such as the community engagement, rider education, some member outreach, and the opportunity to engage in local organizations.
as well as managing these regional advisory councils. One that would be for providers in order to bring those providers together, help them build strong networks. And one that would be for participants, so for members that live in the area, in order to really make sure that the plan is responsive to the needs of that particular region. Slide. In terms of defining regions, we did not specifically get into that, but we did land on this kind of sweet spot of 5 to 9 regions. Again, that would be non-overlapping and really trying to look at and build off of existing public health infrastructure and other current sort of boundaries and systems that exist for them to help there.
Thank you, Lee. Chair, I respectfully submit this to the board for consideration on our straw proposal, which is included in the packet.
So is there a motion to approve the straw proposal for an administrative structure of a universal health plan as presented in the materials?
So moved.
Is there a second?
I will second.
Any discussion? Go ahead, Mike.
The,
Oh, sorry, Mike.
Go ahead.
sorry, go ahead. You go ahead, Mike.
I have every intention of voting for this. There's just a couple of comments here. One is that it's hard to vote anything other than a tentative way when we haven't defined the regions, right? So there's just I have a logic issue with this one. And so I'm assuming this will be revisited once we eventually answer the question, how many regions and what are they? My second comment is that I'd like us to be a little bit clearer about how we think workforce development and innovation actually happen in reality, not in theory. I'm concerned that there needs to be a balance between what's happening in a region and what's happened centrally. And it's been my experience that without some central direction for innovation, groups can flail. And that leads me to my last comment, which I think Lou made today in the feedback he gave us, is that we need to figure out what the cost of the regions are going to be. Because we need to be careful what we're asking for, because we will get, I don't think it necessarily needs a lot of bricks and mortar and a lot of cost, but I do think we need to be able to revisit this once we get a sense of how many regions and what the budget for that would be. Otherwise, we will be creating a potentially duplicative administrative structure.
Judy, do you want to respond to that?
Yes, thank you, Chair, and thank you, Mr. Leahy, for your feedback and comments. Also, thank you for your service on the Operations Committee, which is where this work gets done. Just to remind the board and the community members listening in, the intention of the straw proposal was to get the general direction of the committee's work from the board. And so the intention is that this is not detailed. It's whether or not we're going in the right pathway. So for this, we seek your support.
Michelle, go ahead.
Thank you. I really appreciate the work that the committee has done, especially and specifically incorporating concerns and feedback. I saw concerns that I had raised and that I heard other board members raise in previous conversations, engaged with in really thoughtful and specific ways. And I just want to emphasize, as someone who lives and works and has lived and worked outside of the Portland metro area my entire life, this is crucial for maintaining trust and engagement for communities who don't live close to Portland and Salem. I cannot tell you, I can't stress that enough. And I think that said, there are, I think, the concerns about cost and, making sure that the role is specific and appropriate and that there is clarity on the role of the centralized system versus the regional hubs. I really saw that engaged with in a thoughtful way that made a lot of sense. Some of the concerns about how this current coordinated care organizations operate and the fact that, communities have a lot of questions about them being able to hold, have reserves and those types of things. That was all addressed. So I am in strong support and just wanted to express my appreciation for hearing tough feedback at earlier stages of the formulation of this concept and incorporating it. And again, yes, of course, this is general direction, but I just really appreciate the way that concerns were responded to. And I think this is a really strong straw proposal, and I feel great about it. And I would just encourage anyone who lives close to Portland and Salem who want to centralize to talk to people who live and work in Eastern Oregon and Southern Oregon on the coast. Yeah, that's my comment. Thank you.
Thanks, Michelle. Sorry, Mayor LaCoy.
Okay, I would say to that I am both mostly a city person, mostly Portland. However, for 10 years, I've been married to someone who was most always rural persons and actually have homes out in Eastern Oregon as well as Portland. So I do hear both sides. I'm out there, kind of back and forth. My only concern really about the proposal, and I do voice the things that I heard that, from Lou in terms of costs, et cetera, and how big things get, whatever. But one thing for example, on page 5, regional function number 2, innovation. Find, the idea of some kind of innovation budget could be created for, various things, but I was concerned about saying, for example, increasing certain provider payments. My way of thinking of this is kind of the mothership really does establish the payment mechanisms and the payments. And this to me, if I were one of these people, that was going to be on this regional thing, I would say, well, if we have a budget and, we can decide we're going to pay our primary care people less, or we're going to pay them more or whatever. I don't think that was the intent, but it just was this, for example, increasing certain provider payments made me kind of wonder, what was this and what was our intent? So that was my issue. Other than that, I will vote for it. Amy?
I'm just curious if Judy can speak to that intent, because I'm thinking about how attracting providers to rural areas, if that was part of it, or.
I'm happy to respond. Is that all right, Chair?
Yeah, of course, yes.
Thank you. Thank you, Amy, for the comment. Yes, and I was thinking along the lines of how we need to recruit teachers to rural areas, especially, and we're thinking about behavioral health, and how do we create this workforce pipeline that enables folks to actually live in places that may be really expensive to live, but we need their services. So there may be some innovative models to figure out how do we help with temporarily housing a provider, for example. Who knows? There's going to be some creative and innovative ways to help fund in a region that's specific that you may not need in another region. That's the intent behind the innovation.
Yeah, I don't think the intent was at all to change the way primary care providers are paid. I think that there's a lot of unlicensed providers, especially in the behavioral health world, that there's a lot of support services that exist, and we wanted to give regional entities some authority to use a discretionary budget to encourage the kind of care that they felt would enhance the care in that region.
Okay, just so long as it isn't that we're gonna start having differing ways.
No, they're really clear. Yeah, it's only that the central level that any risk is borne, any financial risk is at the central, but there is a discretionary budget for regions to have some control. So there's been a motion and a second. Is there any further discussion? Okay, we'll do a roll call vote.
Helen Belanca.
Yes.
Chen Wei-Chi is absent. Amy Fellows.
Yes.
Michelle Glass.
Yes.
Bruce Goldberg is on leave. Judy Richardson.
Yes.
Joe Ramirez is absent. Mary Lou Henrich.
Yes.
Michael Leahy.
Yes.
That's everyone. Thank you.
Somehow we've managed to catch up on the agenda. So I'm going to pass it now to Amy and Michelle for, oh, sorry, Judy, I didn't mean to cut you off. Is there any other updates from operations?
No, thank you, Chair.
Okay, thank you. And I apologize to Jessica and Laurel. I don't know if you're still on the call. We're really grateful for your attendance at this meeting and your support of this process. And thank you for the report. We'll extend our gratitude virtually too in case they dropped off, but apologies for missing that stuff. Thank you so
Okay,
much.
thanks,
Okay.
Ellen. Appreciate it.
Oh, you're still there. Yay, thank you. Thank you so much, Jessica. I really appreciate it. Thanks
Yeah.
for being.
Our turn.
Yes, and then I'll pass it to Amy and Michelle. Yes.
Okay, so I'm gonna do the first piece around the mission statement. Michelle's gonna do the second piece around the policy. So we've looked at these before, but just a reminder that I think we originally had 5. We have gotten down to 2 versions of the mission statement. And based on feedback, these 2 options have been shortened. They both share the same core values: universal access, equity, affordability, and sustainability. They take different approaches and how they frame them. I do want to note that the Community Engagement and Communications Committee feedback was that the general group prefers, had expressed preference for version B due to more direct language, clarity, simplicity of language that resonates with regular people, not just policy wonks or healthcare professionals. And that version A seems softer and less direct. So they're both on the board, on the screen, and in our handout. So I don't know if people need a moment, and if somebody wants to move
I move that version B be accepted as our mission statement.
Great. Is there a second?
I'll second.
Mike, second. Any discussion?
Aye.
Go ahead.
This is to Amy. I'm, entering now, so I'm, catching up with you guys. Both of these sound really good, but my gut is like yours to version B. But I liked the dimensions of both of these, so I almost saw it as an and I don't know how you do the and, but I agree with you, and will support your direction because you've thought this through a lot more than I have.
Any further discussion? Okay, so the motion on the table is to approve version B as the Universal Health Plan Governance Board's official mission. Go ahead and do a roll call.
Helen Blanca,
Yes?
Jen Ritchie is absent, Amy Fellows,
yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes, thank you.
Joe Ramirez is absent, Mary Lou Henrich,
Yes.
Michael Leahy.
Yes.
Thank you, that's everyone.
Thank you, and thank you for your hard work on that. I know that was it was a really interesting process, and I think that's a really useful process to really think through and get specific about our mission. So yeah, I'm really grateful for that. Okay, go ahead. Continue. Michelle?
Thank you, Chair. And thank you to the board and the CECC for all the 6 months of thoughtful work on this mission statement. I feel really good about where we landed. So to continue the report out from the CECC, the Communications and Community Engagement Committee, we presented to most of you. Thank you so much for being generous with your time on a Friday. On October 31st, on Halloween, we set aside some time to really talk about this moment that we're in, the next phase of work we're entering as a board, as we get closer to having more solid plan, financing and revenue design and eligibility, and all of those components of the plan that we're creating in our committee work and the straw proposals. We talked about how there would be more focus on the board's work and that we really are entering a new phase where people might be hearing about us for the first time and be more interested. So we did present this proposal and in depth and kind of discuss it at that meeting, because today's such a packed agenda and we're really trying to focus on solidifying those that general direction from the board on the plan elements, so we can move forward. Unless there are specific questions, don't plan to go through the entire proposal again today. But again, the proposal, just to refresh us quickly, was for formal written materials not including meeting packets and internal committee materials that would be designed for an external audience would all go through our communications and community engagement process, which includes review by our communications consultant. Thank you to the board for ensuring that we followed that with our report to the legislature in the previous motion. So formalizing that in our policy is part of this proposal. The second part of this proposal is making sure that the any media inquiries go to our primary designated board spokesperson, which is our executive director. Thank you, Mimi. And third, making sure that board members who are volunteers and doing this huge body of work know that if they receive a request for an external presentation, what the process is to follow. So the process is to notify the executive director, the primary spokesperson, so it can be recorded. And so you can get the most up-to-date slides that reflect the current state of the work. And that if you don't personally have the time to do that, that you can refer those speaking opportunities to the primary spokesperson, again, the executive director. So just adding these three components to our board adopted policies and procedures for clarity and to support all of us in being able to focus on our primary job, which is, this hard work of deciding what the structure of a universal health plan for Oregon looks like. So I respectfully request that the board consider this proposal to add these three components to our board adopted policies and procedures. Thank you.
Thanks, Michelle. So it's here, and I just want to call out again that specifically media inquiries that any board receives should go to Mimi. And then Mimi is our official spokesperson for presentation, but it's not explicit here, but I assume that if she receives an invitation to speak, that she can delegate it if she chooses, but that the goal is to have her as our primary spokesperson.
That's correct. Yes. And I would just also say, if you get an inquiry, I had a board member reach out this week saying, I got an invitation. What's the process? Amy and I are here as a resource. If you have any questions, I'm sure that Mimi is as well. So this is our process that we all commit to following as we, if this gets adopted. But if you have questions, 6 months from now or 3 months from now, I'm happy to be a point of contact as well.
Okay, I happen to be the person who called Michelle to say, okay, I got a request to speak to a graduate health policy class at Pacific University. So I was saying, I know that we had the slides that, whatever. So I went to look on the public stuff trying to find it and found they weren't there. Then I was told, oh, call Mimi. So I sent a text to Mimi that said, this is the deal. And I'm glad to do it. I think it's a relatively small group. And I'll use the slides, but I'll talk to you about how to do it. So no problem with that. One word on the number 2 on the informal communication general guidance, first dot point, do not share confidential or speculative information. I'm just wondering, with everything being so public, do we have anything that's confidential? I mean, I would not want to share anything, but I'm not sure in this process. It just feels to me like as a board member, I don't know, I'm wondering how would I know if something, I stick to the talking points or whatever, but I'm just kind of like going in a public process like I have, is there anything that is confidential that anybody might have? I was just wondering what that was. That's all.
It's a great question. Can I respond?
Sure.
Thank you so much, Mary Lou. I appreciate your thoughtful question. So it's not common, but the board has had to appropriately go into executive session, for example, for hiring, right? Those are instances where it is appropriate and important that we abide by confidentiality for, we employ people as a board. So that's one example. There's not a lot, but that's one that comes to mind. I hope that's helpful.
In executive session.
Anything in executive session certainly is confidential, yeah. And then the second part of that bullet point is speculative information.
Yes.
This is a board that's trying to create something new, and there's a lot of ideas that get tossed around, many of which, maybe most of which, aren't going to be incorporated in the final plan, and I'm guilty of this as well. I think it's easy to start speculating about what might happen, or what could happen, or what we're thinking about, what we're talking about. And I think we just all need to have a lot of caution around speculative information, because especially when we're speaking to general audiences, to really only talk about things that have had sort of board approval, or that we know for certain that will be incorporated. So being really cautious about speculating. Judy?
Oh, thanks, Chair. I was just ready to move to adopt the updated communications
Oh.
proposal as presented into our policies.
Great. Is there a second? Second. And Amy second. Is there any further discussion?
I think it's terrific.
Okay, we'll do a roll call vote.
Helen Belanca,
Yes?
Jen Chi is absent, Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez is absent, Mary Lou Henrich,
Yes.
Michael Leahy.
Yes.
Thank you, that's everyone.
Thanks. And again, I'd just like to express my gratitude to Amy and Michelle for all your work on this, and for guiding us through this process and working with Patty. It's great. The one pagers have already come in use, and it's really been a great process so far. So thank you. Okay, with that, I'm sorry, go ahead, Michelle.
So sorry, real quick. I did want to just circle back to the committee updates briefly. As you all know, I think we reported out in October, we have completed our communications work stream. The materials, all the core materials that have been developed by Patty will be updated as planned. Straw proposals are approved by the board. But the major lift of creating all the preliminary materials for the work of the board is complete. We are shifting focus to our community engagement work stream, as we shared with you all on October 31st. And as such, we have done all of the preliminary work we can do with the Community Engagement and Communications Committee. And the work of the next couple of months will be internal with Diana Bianco, Patty Wentz, staff, and the consulting with the chairs of the committees developing the different aspects of the plan. So operations, plan design, finance and revenue. And so to respect the time of the CECC volunteers, we are pausing, as of yesterday, we have paused the CECC monthly meetings until April, at which time the committee will return to review the report on the engagement that Diana Bianco of Artemis Consulting will have completed by that point. And then they will help us to plan and implement the wider dissemination plan for whatever the plan is that we're going to be submit to the legislature, to make sure that we're also doing what we can within our limited time and monetary and capacity resources to get that to a wider audience. So I did just want to let folks know, anyone who's listening in here, that those meetings will be paused. We'll have a quick check-in in January with the committee just to give a status report and have some discussion. But just wanted to update folks that the work is continuing, but the committee has already given all of their feedback to Diana on, their ideas for who to reach out to, their ideas for question drafts. And so they are, there's not a role for them right now. And so we're giving them a break after all their hard work on the communications materials. So much gratitude to those hardworking volunteers. And they will be coming back to help with the heavy lifting again in April and through September. So thank you.
And while we're on that, as Michelle and I are going to repurpose some of our time to engage in the other committees.
Oh, great.
So that we better prepared for the community engagement piece.
Great, that's a great idea. That's a great idea. Thank you. Appreciate that report out. Great, with that, let us take a break. It's 10:30. We can come back at 10:40. Thank you.
Reconvene.
But it's not in common, since we.
Okay, we are gonna pull back and get started again.
Yeah, I just read about the history of it.
And first on our agenda after the break. Oh, do we have everyone back? Sorry, how we for Isabel. Great. Great, so first on our agenda is plan design and expenditures. I'm still the interim chair of that committee. So in our last meeting, we covered quite a bit of ground. We had an extensive presentation from our Milliman consultants on healthcare expenditures, both our current expenditures, projected expenditures if we remain with the status quo, and then projected expenditures of the universal health plan. That was a really interesting and detailed report. We learned a great deal. If it's okay, I'll ask Isabel to pull up, I just want to show two of the slides that Milliman gave us because I think they're of interest to the board. These are the expenditure projections that they gave us. The slide's a little bit hard to read, but the top three lines in the chart are if is for status quo. And again, they're still using the 2030 projection because that's what we've been talking about. So if the UHP does not happen, the projected healthcare expenditures in 2030 are in the 66 to 72 billion dollar range. Optimus put the status quo estimate for 2030 at 71, so they're about equal there. And then the second two lines refer to if the UHP was implemented, what are our projections for healthcare costs? And the projected healthcare expenditures with the UHP will be between 74.5 and 86.4 billion dollars. My numbers there are slightly different than what it says on the chart, and the next slide will tell you that, but hang on one second. They added something to these that we are going to be removing. But basically, the projected cost of a universal health plan is somewhere between 74.5 billion and 86.4 billion, which is quite a bit. Go ahead to the next slide. Where they see that extra cost coming from is basically the addition of PEB level benefits for everyone in Oregon. Right now, not everyone has that level of benefits. So the cost of bringing everybody up to that level of benefits accounts for about 3.6 billion. Induced utilization is basically accounting for people who will likely use more health care services if they are not having to pay out of pocket for them. Particularly where this came up is dental. There are quite a few people without dental insurance and quite a bit of unmet need there. So there's that box as well. Adverse selection refers to in-migration of people who might move to Oregon because of the healthcare environment here, which would be favorable. They did a really interesting analysis of this, considering what conditions people might have that might induce them to move here, and the increased likelihood of people moving from close by states. And then the final box is the uninsured folks who are currently uninsured that would now be covered under the plan. Accounts for another small piece. The top left box here says non-resident workers. That was an error. There was a miscommunication. This board has decided that the universal health plan is not going to cover non-resident workers, that we will make some other accommodation for them. So people who live in other states but work in Oregon. So we define eligibility as living here. So that top left box, that 3.4 billion, that's the number I subtracted out from their estimates because this board decided we weren't covering them. So they are revising their estimates. They are going to give us some 2032 projections and cover that. But I thought that was really interesting data just to share with you all. And then the other pieces of work that we have been doing, you can go back to the regular presentation. Thank you, Isabel. Is working on two straw proposals. The first is a hospital payment straw proposal. As the board recalls, the legislation specifically calls out that institutional providers will be paid with global budgets. And so Lee has done a tremendous amount of work on this and drafted some proposal fundamentals about how we would pay hospitals. Basically, that hospital global budgets are the primary methodology to reimburse acute care hospitals, and that the global budget would account for about 70% of total hospital payments, with the remainder consisting of activity-based quality and performance payments. That it would cover both inpatient, outpatient, and physician services. And some methodological adjustments are going to be made for critical access hospitals. And then the timeline we proposed was over 3 to 5 years. And that hospitals would begin with 30% of their anticipated payments covered by the global budget and progressing up to the 70% over 4 years. So there's a lot more detail in the written materials included in your packet, but that is the basics of it. Does anyone have any questions? Go ahead, Mike.
I had a question both on the previous graph and on this one.
Yeah, mine's on the previous graph also.
Okay, go ahead.
Can you? move
The
to
middleman,
the-
yeah. Or
Yeah, no.
The next
The middle one.
The middle one. Yeah,
Ah.
okay, so there are some phenomenons that when you transition will cost, but some of them really aren't ongoing costs, they're one-time costs, and it might be useful, for instance, to, if that's 2030 to at least crudely extrapolate in
Yes.
2035, because there are some things like catching up, people haven't had dental care,
That's
haven't had X. But once things stabilize, and I base these on my both public health and Kaiser experiences. There's there could be a lag for some things a year, for something 6 months, for some 24 months. But it's almost leading to think that would be annualized, that
Right.
I would put it almost into some of these into transition costs and not into comparing things.
And it seems like with the market, with the OHP expansion, when we have some data on.
Okay, so hang on a second. So 2 things. One is, yes, this is just the 2030 projection to give us a sense of starting costs. And Milliman is currently working on actually a 10-year projection. Some of the increased costs, particularly induced utilization, we know from other folks, the pent-up demand, it tends to be around for, they predicted, about 5 years, and then it tends to go away and kind of even out. And so, yes, they are projecting it's going to be eventually be a multi-year projection, but they just wanted to get these initial numbers in front of us. And specifically calling out that if we did nothing, our healthcare expenditures in 2030 would be 72.7 billion, and with the UHP, it would be 89. Again, minusing that 3.4, it's about $11 billion. Additional that we would have to pay for the universal health plan. And so it's just to give the board a sense of what the initial expenditures would be. I will point out that this is strictly paying for healthcare. This has nothing to do with administration. In case that's a question that people have. This is just the actual claims of actually people getting care and hospitals getting paid.
But it could be administration at the hospital or the provider. You're talking not administration
Of the plan. That's right. Yeah. Go ahead.
And on the uninsured, that takes into, or I'm asking it, does that take into account?
HR1.
Yeah.
Yes.
With all the
Yes.
ACA changes and the people who will fall off Medicaid and not be able to do.
Right. I'm showing you a very abbreviated one. They did for their first projection for 2026, which incorporates HR1.
Okay.
And then took it from there to 2030.
Okay.
Yes. Go ahead, Marilyn.
I guess one of the pieces that just I believe, and we have the data to show that some of these concerns, when we expanded to the OHP, there was a lot of concern that all these people were going to move to Oregon.
Right.
Because we had it and others didn't turn out to be that way.
Right. And I think that's what Amy was alluding to before, that there is some data now in our.
Yeah.
Yeah, but I guess I would point out that folks who qualify for Medicaid by definition are low income.
Right.
And it's much harder for folks who are low income to move.
Yeah.
And
But people who are high income, when we look at our proposals for the payment of this, they may say,
Right.
I don't want to come here
Right.
for that. So it's a.
You know, we
Crystal
asked
ball.
them how they came up with those numbers, and it is a fascinating and super interesting process to make those projections. There was some rigor to it. There's some, thoughtful, rational ideas of how that would happen. It's not a number that they've pulled out of their hat. I'd encourage you to look at our meeting materials if you're interested in their methodology for how they came up with that number, but they felt that that was a reasonable assumption to do that. But they are going to be looking at the migration data around when some states expanded Medicaid and others didn't, what migration happened there. But I think it is a different population that would migrate.
Yeah, and I guess the other thing is they've looked at all these things. I'm not gonna go into that, but I do think that the Finance and Revenue Committee has been saying, and Cheryl's not here to say it today, but that we really do think we need to get together with the plan design, this kind of piece, because we have some
There's got to
other
be some
projections
reconciliation.
and reconciliation, and we've got to have that discussion
Absolutely.
with Milliman, with Echo, with us.
Right. Yep. That's in the works.
Okay.
Um,
Hadn't heard it.
go ahead, Mike. Or, sorry, Mimi, did you want to?
I just wanted to respond to two things. One, for Mike's initial comment, I just received a message from Fritz Bush. Just that Milliman is indeed reducing costs for later years due to the pent up demand, as Helen alluded to. So that is one thing. And then to Mary Lou's point, absolutely about the finance and revenue and the plan design and expenditure, Milliman and Echo Northwest definitely are in conversation. And so that is happening.
Okay.
Just to make sure, and more to come, I would say.
But I do know committee members have been pushing that we'd like to have a joint committee meeting.
Yes.
So I'm just speaking for the committee.
Go ahead, Mike.
So no, I have, I think it's just a clarification, but on the proposed fundamentals.
For the hospital proposal.
Yeah.
Hospital payment proposal.
Yeah, the wording here says implemented over 3 to 5 years, beginning at 30%, says, and increasing 10% over the next 4 years. I'm assuming that means 10% per year.
Yes.
Okay, maybe it should say 10% per year, because it's easy to read that as only 10%, and then the math doesn't work.
Got it. Right. So, right, second year, 40%, third year, 50%. I'm getting up to 70%.
That's one of those things you want to get right.
Yep, we can make that adjustment. Thanks. So is there a motion to approve the hospital payment straw proposal?
I'll
Mary Lou,
submit the, yeah.
make a motion.
Make a motion, that's it, thank you. Bring part there.
I'll second.
Any further discussion about the hospital payment straw proposal? Good work. You, great, we'll do a roll call vote.
Helen Belanca,
Yes.
Shenhui Chi is absent, Amy Fellows. Yes. Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez is absent, Mary Lou Henrich,
Yes,
Michael Leahy.
Yes,
That's everyone, thank you.
Great, so the other piece of work that the Plan Design Committee has been focused on is a quality of care strategy, straw proposal. I want to extend appreciation to Mimi for all of her work on this. The straw proposal goes into great detail about how the state could set up a quality level strategy and policy to make sure that the care provided meets the highest standards. The high level summary includes 8 core components of the quality strategy. And it would be based on the World Health Organization handbook for a national quality and policy strategy. Mimi, do you want to explain any more about the proposal?
Thank you. I think just this sense that, again, this is not a set of specific metrics that we came up with, but rather a framework in which a quality policy and a quality strategy can be developed at the statewide level. And really the number one thing is getting the state health priorities. That's number one on the list of the 8 elements is, so there's a lot that goes into it. So people do have the chance to look through it. I would encourage you. It is, as I say, it's a little bit meta because it's sort of planning for how we plan for something. But that's what's needed at this level, as opposed to, certainly at this point, it wouldn't be appropriate to select specific metrics or things like that. So it's more guiding principles, policy and strategy.
Right, and the committee was really pleased with this proposal and thought that this was absolutely the right way to do it, is to just give direction on how you would develop a good quality policy and strategy. And so this was well received by the committee. Yes, go ahead.
I think one thing that we haven't really brought up at this board level, and I'm not sure how it even, I don't know specifics at all. I just think that we have not discussed AI and the implications that AI is going to have for the whole system of how we do everything and deliver, et cetera. So I just think there are, it can either be like, ugh, or like, whoa, maybe there are savings, maybe there are different, easier ways to do things. Mike keeps telling me about this AI stuff, and I go, okay. But anyway, I just wanted to kind of interject that we need to kind of maybe be thinking and at some point as we go along. My other thing is a question that really goes back, I'm sorry, to the straw proposal on the global budget. Something that I hadn't really been paying a lot of attention to or thinking about until someone brought it up the other day, is that so many physicians are not out there in any kind of solo or small group practices anymore. They have gone to work for hospital systems. And so when you're talking the global budget thing, is that kind of also, as we think about, how do we pay primary care or how do we do whatever, that it may end up being a relatively small group of people that aren't just kind of under the umbrella.
Well, it's a little off topic, but
Okay.
It doesn't include primary care, but it
Okay.
does include any physicians employed by the
Employed
hospital,
by the
which is
hospital.
mostly specialists, but
Oh, is it?
might be some,
Okay,
yeah.
all right.
But yeah,
Okay.
we can talk more
All
offline
right,
about
that's
it,
all.
but, yeah.
All right.
Judy has her hand.
Go ahead, Judy.
Thank you, Chair. I just want to call out how well this straw proposal is written from about quality, and I really commend the calling on the IOM's 6 main domains of healthcare quality, because it gives the philosophical framework for these founding documents for the Universal Health Plan going forward. And you can always call back. One of the things my students struggle with most is how do we define quality? And starting with a document like this, I think, is really strong. So thank you for how well it's written.
Great, thanks. Is there a motion to approve the quality of care strategy straw proposal?
Chair, I will move to
Okay, great. Judy, and then a second?
I'll second.
Amy seconds. Any further discussion?
Michelle.
Go ahead, Michelle.
Very briefly, I agree. This is really great to see and well crafted and very thoughtful and aligned with a lot of other really reliable sources. I'm excited to see this move forward at such an early stage. So thanks for that proactive work. My one request is under criteria for assessing quality indicators. I do see strong alignment with the straw proposal and our values and principles. I think that if people were looking at these criteria for assessing quality indicators, I think it would be helpful to name somewhere in here health equity specifically, because as I read it, looking at health priority and scope of impact, specifically, using the examples of population size and clinical outcomes, I could see a real concern that this would lend itself to maybe missing really deep disparities for smaller populations in Oregon, which has been a longstanding issue and concern, and why health equity has become such a focus. And I know that is our overarching value in our board adopted values and principles. So just a request that we could find some way to explicitly acknowledge that in case anyone else reads this and has the same worry or question. I know that's not the intent. I'm wondering if there's just a quick, in addition to population size, maybe we could say, something like longstanding disparity or something along those lines to make sure that people understand and see themselves represented in this if they come from one of those experiences. Thanks.
So you're referring to the page 8 of the proposal. I would propose that under number 1, health priority, that it says right now, does the indicator measure a specific health priority? I would say including something related to disparity. So pressing health concern, epidemic, global community outbreak kind of situation, or health disparities in there. But I don't know, Mimi, what do you think?
think I'm gonna have to think about this for a little bit, just to make sure that I get the verbiage right. I don't want to say anything.
Yeah.
Like right today, but I think that I can, definitely look at it. I might do a little offline chatting and then also, definitely come back with some different phraseology. Again, this is just a proposal, but I'm very, very appreciative of that comment and wanting, I mean, absolutely wanting to make sure that that is highlighted.
Okay, so we will, we'll adjust that. Great. Any other discussion? Go ahead, Mike.
Actually, Bill's on that point. I, as you all know, I'm trying to catch up with you guys, and I've been talking to lots of people, including few doctors and nurses who actually do quality measurement. And the one thing they stressed is not learning from the theory of the last 20 years of quality as much as that a lot of the places underappreciate the patient experience. So I would somehow add in, now, I briefly discussed this with Mimi, and she said, maybe we can keep where we are here, but recognize that in the implementation, that's where that will come in. So I don't necessarily suggest any language, but I do agree with the previous comment about both equity and it's really diversity of patient experiences. I mean, we can have all this quality stuff, but if it doesn't satisfy Oregonians, that's kind of to me the acid test. And that's the feedback I've gotten.
And there are patient experience metrics.
Right. Great. Any other discussion? Okay, we can do a roll call vote. And this is to approve the quality of care strategy straw proposal.
Ellen Blanca,
What's that? Amy, did you have something?
Oh, just that will continue to be.
Yes,
Yes,
again, the straw
okay.
proposal, iterative process.
Direction.
Modified to specifically
Yes.
call it.
Absolutely.
Yes, okay, yes, go ahead.
Helen Blanca,
Yes.
Shenwei Chi is absent, Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez is absent, Mary Lou Henrich,
Yes.
Michael Leahy.
Yes.
Thank you, that's everyone.
Great. So now we'll move on to finance and revenue. Chair Cheryl Ramirez is not here, but I believe Charlie Swanson is here to Richard Gibson. I apologize. I was looking at my. Is here to give a.
It was me.
Oh, is that you?
Yep. Well, that was, excuse me. Yes, so, our plan was as mentioned, Cheryl Ramirez is not here. I will do some of the presentation, play by play, as it were, with Richard to provide the, in-depth color commentary and, further about elucidation of, what we're discussing. So we can go on to the next slide. So for the purposes of this, we're going to discuss again the, revenue proposal that was put forth. The initial proposal was put forth at last month's board meeting. So I'm going to review that first. It's a summary of the points of the preliminary proposal. And then we will go on to discuss the feedback that was brought to attention of the committee and our consultant groups. And then we will go to the response to that. So there's a lot of things, moving parts here. So, but we'll start with this just to sort of ground everyone what we started with. And again, this was last month, so that there would be an employer payroll tax. Tax levied on employers based on total payroll with a defined threshold. There would also be and again, this is in Oregon. I want to make sure and say this. I can hear John Santa in my head saying an Oregon employer payroll tax, an Oregon healthcare personal income tax, applied to individual income above a certain threshold. There was also at that time that a proposal for a per person premium, which had a cap on it and which was phased in at again elevated incomes. The proposal included an employee tax credit. So in other words, that would come from the state to offset the employees in health care personal income tax liabilities. And then also the idea of a soft cap. So at some point, a person's healthcare personal income tax rate might go down after an individual's combined direct contributions, and at the proposal stated something at that the contributions exceeded 30,000. So again, those are preliminary proposal, so I don't want to spend too much time on that. Okay, so if we can go on to the next slide. There's incredible feedback, both from the board and from the public. We're so grateful. Number one, that there were equity concerns, that the per person premium and the soft cap disproportionately benefited high income households and really put a burden on middle income households. And then that the regarding the treatment of Social Security beneficiaries and Medicare participants, that they would essentially be paying twice if they were having to pay a Part B premium and having to pay a healthcare personal income tax. So in other words, that they were getting equity concerns regarding that. So that's some of the feedback. Next slide. The other very common comments were that it was very complex. The structural complexity made it very difficult to explain, that the layering of taxes and credits and thresholds, that it created confusion. And again, difficult to explain. So in other words, to talk about how the per person premium worked, or the tax credit were to work in relation to the employer payroll tax. So again, this is the feedback that came back in. And next slide. So there were some specific recommendations that were made. So one, to remove the per person premium. And to consider graduated healthcare personal income tax rates instead of just a flat rate. And then also to evaluate both the employer payroll tax and the Medicare Part B credit structures. Okay, so that was the feedback that was obtained. And now we're going to go on to the next slide. All right, so this one I am going to slow down a little bit, because I think this is really helpful. And actually, I'm going to call Richard. Do you want to talk about this one? How it says per person premium eliminated, which maybe is not the completely appropriate word, but replaced by household-based healthcare personal income tax adjustments.
One of the criticisms of the previous plan was that we had a healthcare personal income tax table, personal healthcare income tax, and then we separately calculated a per person premium, and we added them together and said this will be the extra taxes that Oregonians will pay in addition to regular Oregon personal income tax. We had both a healthcare personal income tax and a per person premium. We added them together to get the extra amount that Oregonians would pay. So instead of doing it that way, we have a single tax table that includes the healthcare personal income tax and a family size rate readjustment. So that every other thing staying the same, bigger families pay a little more than smaller families. And that's built into a tax table. So it's not creating two different calculations. It's one table that shows the calculation. And it's a family size rate readjustment. So there's more to discuss, but that's this issue here.
And I apologize, I initially had the older slides. These are the updated slides with the appropriate. So this is the one that has the different, yes, let me pull this over here. Just the slightly different verbiage that you had recommended. So, so I want to take a moment and see if there's feedback or discussion about this point, because this is big.
I have a question, and I don't know if it's going to get addressed later. But in terms of looking at the family size, if you have, I guess it depends on like what happens long-term with Medicaid and those things. But if you have like some family members are on Medicaid and the parent is not, and there's like a mix of that, there could also be mixes of some on Medicare and some not, you know, depending on couples and their ages and things like that. How is that accounted for, or just assuming we're no longer looking at Medicare and Medicaid?
Thank you, Charlie, if you can see it popped right up. So one, family size rate readjustment only happens at higher incomes.
Oh, okay.
So that's one thing, and we do
But-
have a graph
but-
that shows that.
Families with disabled children are at all levels of income and through the K plan qualify for the child to be on Medicaid.
Right, but I mean, this is, I think that's assuming that Medicaid is still working in the way that it has been working, and this is a different.
Okay, that's my
assumption. So,
question.
yeah,
Okay.
so I guess, yes.
I guess that would be my thought too, from the committee, that there really isn't. If this really happens, there is really not Medicaid anymore.
Okay.
There is everybody under this plan, and how the money funnels in is, of course, we want some Medicaid money, but it's not like, and that's, I think, the beauty of the plan, is that people will all have, and as Bruce Goldberg used to say, there won't be wallet biopsies. That it will be, you all have a card, that you are an Oregon. Health,
As long
you know,
as we
whatever.
don't forget the
There will be
community and
extra
home
benefit.
services.
No, they'll be
that-
included.
Okay.
That'll be part of
Part of the
it.
benefit structure.
Benefits.
But, right, but what you pay doesn't depend on
Okay.
how you qualify for healthcare.
All right.
Qualifying for healthcare, just, you live in Oregon, you qualify, it doesn't
Right.
matter your disability
And
status.
you just
you
have a card that says you're,
Right.
you know, whatever we call this thing.
Right.
Okay,
Okay,
in different iterations, we've talked about different carve outs. So
Yeah. no,
Make sure.
we don't want that.
Okay.
At least from our committee's perspective.
Thank you.
All right, so, Helen, I just was thinking that it might be worthwhile just, addressing these as we go along, because they are really complex.
Yeah, so my question was about, is the adjustment to the HCPIT, is it roughly equivalent to what the PPP was, or did you change that $4,000?
So any changes that occur in any of the assumptions or inputs can change a lot of the numbers so that you still end up with the approximately 16 billion that are needed.
Right.
But I think the answer to your question is generally
You
yes.
generally just
Yeah.
moved over.
It's on the order of $900 to $1,100 per additional person.
Great,
That kicks in at a medium and higher incomes.
okay, I think that's fabulous, I think that'll be really helpful, that piece alone, just what's your income, what's your family size, and
Yeah.
then start there, yeah, that's great. Mike,
So I have a question for Richard and Charlie, and that is, a lot of international research tends to say things that are successful is what kind of everybody in the community has skin in the game. And I know this is difficult because we're now used to, you either are totally screwed because you don't qualify for the OHP, or you get everything with the OHP. And I'm wondering to what extent you've wrestled with this phenomenon. I mean, even if everybody participates in some meaningful way, I think that gets us back to a more respectful way of treating fellow Oregonians and the like. And I'm not suggesting it needs to be dollars, but there needs to be something so that everyone has some skin in the game in this universal health plan. I'm just wondering if you've wrestled with that, or if we have to think that through a little bit more deeply.
Yes, the Finance and Revenue Committee has clearly heard that issue of ownership. And I think we're gonna visualize that discussion on a slide that Mimi's gonna bring up here in just a bit.
Great.
And it'll facilitate that discussion.
He didn't have me ask that question, by the way. This is not a setup.
Can I add one more thing, Mimi?
Yes.
That there is in the committee, though, at least as long as I've been there, and Helen even had brought it up as a recommendation before, I think we have been basically thinking that people who are not paying anything for healthcare now, that are on the Oregon Health Plan, I do think we have shielded that, whether that's the right thing to do or not. That it's, if you are not paying anything now, we have not wanted you to pay anything going forward, but that's really a question. Then you really do end up with not everybody feeling they have some skin in the game, whether it's $10 more on their income tax or something like that. But I think we have tried to shield and to be able to say to people, if you're not paying anything now for the Oregon Health Plan, and that's 1.2 million people, that you're not going to be paying anymore when this comes into being. At least, Richard, do you agree that that's been what we've been talking about?
Yes, and that's one of the inputs that the board will have to make in
Yeah.
approving the straw proposal.
Okay. Next slide.
No.
So this kind of gets to the point that Amy was speaking about. So this slide shows the amount that people would pay based on the number of, so looking at number of exemptions, which is on the bottom and goes towards the right. And then you have the different lines, sorry, you didn't get a chance to get it completely cleaned up, about people's income. So those are the different lines or income levels. And this is without a household adjustment. So in other words, if there are a certain level of people that you see, it's a relatively straight line because people do have the number of household exemptions. And I think what is helpful is then if we compare it with, so this is the one without the sort of PPP wrapped in there without household adjustments. And then if we go on to the next slide, so what you'll see is that for the adjustments, what happens at the lower levels of people's incomes, there is a less of an impact of the adjustment, and that those who are at the higher income, I'm trying to say that correctly, at the higher income levels, their number of exemptions does make a difference in terms of the amount that they pay. So in other words, if you have at the lower end of the income level, the more people in your household, the less that you pay.
So the Oregon income tax form, the 40, asks for the number of dependents in the household. And in this case, we call that exemptions. And if we go back to the previous slide, if you would please, you see exemptions across the bottom, and you see that that in general, for a given number of exemptions, higher incomes pay more as a rate than lower income at the same number of exemptions. So that's one concept from there, and that's progressivity. The second thing is that at a given income level, your rate goes down as your household size increases. And that's kind of the typical effect of an exemption, is it raises the threshold for taxes. More houses at the same income, larger households pay less tax than smaller households. Now, what we see if we go to the next slide is putting in that family size rate readjustment. You see it jiggles there now. Higher income families at any given family size pay more than lower income families, but that at any given income level, larger families pay a little bit more for a while than lower income families. I mean, than smaller families. So that's the difference between the two slides, and you can see the effect on this slide. So I'll stop there and see what questions are.
Good. So this is still based on the 9% flat tax.
So again, I want to say which one we adopt and what the level of credit that we'll get to will affect exactly how much the healthcare personal income tax rate is, but it's around 9%. I don't know. Charlie can tell us exactly for these slides which rate that is, but it's on that order.
So why do so many of them start at 6-7%?
Because there's also an exemption for the first 200% federal poverty level before the tax rate starts at all.
Right. Right, okay, so, right, so if you make, you're right, if you're making like $50,000 a year, then, you know, the first 30 or so is gonna be exempted, so you're only paying on that. So it ends up being about 6% of your total income, even though it's 9% flat tax. Is that right? Okay,
Yes.
got it, okay.
And you see at high income, it barely makes a dent because
Because so
exempting
much of your income. is
50 or
up from
60,000 out of 500,000 is not very.
Right, got it, okay.
The people, if you look at the graph, and I've had people's in this income, seems to be the question about the $200,000 family. Because we in our previous stuff have considered that as kind of a higher income. But I've been having people who've been watching this thing say to me, well, we do that, we've got 2 kids, we've got a mortgage, we've got this, we're just barely with our noses above the water in Portland, Oregon. And so don't consider us in the wealthy group, because we're not, you know, and if you look at where this, the exemptions thing, if you look across on the 200 to whatever, you're talking 5.5% or something, and then if you look without the exemption thing, it's a little lower than that. So there are these trade-offs and these questions, and when we talk about these different levels of income and use these terms, I don't know that we've really defined them clearly, so that we say higher income family is, you know, a 200,000, a single person. It's just very complicated, and I keep telling people it's kind of like a Rubik's Cube. There is, you know, we don't have a flat thing. It's like all of these interplays, and the fact that most of us don't really understand what's behind the screen in our own income tax that we pay now, how all of the various things that have been done over years end up with that you put it into TurboTax and out spit something at the end, and most people go, I hope it's a refund. You know, so anyway, we're getting into some bowels of this, and I just want to say the committee has really struggled and worked, and I kind of came in late, and I've been kind of explain to me what this means. Can you help me understand this? Because the people who did it, the Charlies, the Richards, who's gotten really into it, and Echo Northwest helping, they really understand all of those pieces that we currently have, and then how this will affect it. And some of us, like me, are going, huh, is that, you know, so anyway, I don't want to keep on, but I just wanted to tell people that the complexities, and every time you do something, like, I remember Helen saying, well, geez, I don't want anybody who is currently like 200% of FPL, don't lower it down, so that people in that place in between 138, 200 pay more when they aren't now, or, you know, so it's like trying to put all of those things into this Rubik's Cube and come out with something that most of us can say, this is really as fair as we can get it, and progressive.
Along those lines, sorry, what was the justification of the $200,000 mark as sort of definition of higher income? Did that come from some sort of, is that?
No, I don't believe we ever said that.
Oh.
That's just,
It just wasn't played out.
yeah, what she mentioned that, we didn't say that. I think we talked about 200% of federal poverty level
Right.
is, okay, is the
Yeah, yeah.
threshold before the
Threshold
tax.
before you
starts.
start taxing,
Okay.
yeah.
But
No,
we
we don't define high, middle, lower income.
No, and that's one of the things, we don't define it, we just talk about those.
Yeah.
And
Okay,
then
so
people assume things.
Right, so that's to come up later, if like we wanted to do a progressive tax instead of a flat tax, at what point would that kick in, kind of thing, yeah, okay. So right now it's a flat tax, and there's no need to distinguish that, yeah. Go ahead, AJ, you have something?
Yeah, I know I sound like a broken record, but I want us not to forget people who qualify currently based on disability, and it's not the same as being qualifying based on income. And they've already given a lot of skin. There's not much skin to give, or because we're living in a time where we're looking at reinstitutionalization of disabled people and eugenics politics, and I just need to, you know.
So are you suggesting to me that people that have families that have a disabled member in their family should have some different level of calculation of their tax? Or like, so right now, everybody's tax is based on their income, the household income, regardless of who lives in the
Well, I need to understand whether or not, you know, like if you have a disabled adult continuing to live with you, do they continue to be an exemption? I'm not quite there yet. I will be in another year. But
if they're dependent, then they're an exemption.
yeah,
Yes.
so understand things like that, but also when we're talking about the piece about who currently qualifies for Medicaid and whether or not they will have skin in the game.
So there's a benefits discussion and there's a payment discussion, and they're separate.
Okay.
So we are not removing benefits from anyone. If you qualify for benefits, you're gonna continue to receive benefits. That's already decided and settled. Right now, we're just deciding how much households should pay.
Okay.
And how much they pay is entirely dependent on household income at this point. It's not considering, it's dependent on household income and number of people,
Yes.
the number of dependents.
And what I'm telling you is in our current world, if you have a disabled child or a disabled adult living with you, income is not looked at.
according to federal law, K plan. So like just
Right.
keeping that in mind.
For benefits, it's not, but for tax purposes, if that person is a dependent, then they're considered an exemption.
Okay.
Right,
Yeah,
so,
yeah.
so you're referring to the
Yeah.
benefits,
Okay.
they still
All
qualify
right.
for
Okay.
benefits.
All right, I'm
Okay.
confusing them.
Yes.
Okay.
Yeah.
But good questions, those, you know, and those are the kinds of questions we'll be getting from people and trying to help explain that. But the benefits are all gonna stay
The
there.
eligibility
Yeah.
piece.
Yeah, the eligibility piece is separate, we're just talking about how it's paid for.
Right.
Okay.
So,
And everybody, if that person lives in Oregon, they're eligible.
Yes.
For the benefit plan that they need, for all the stuff.
All right, so the next key revision has to do with the employer payroll tax credit, which the potential for setting it below 100%. So in the original proposal from a month ago, the payroll tax credit was set at 100%. Consequently, as you see kind of in the second bullet, at 100%, some high income employees ended up, because they got that credit that their employer, the contribution the employer made, those higher income employees made rather modest direct healthcare contributions. And so based on feedback from the board and from other people, the recommendation is that the employer payroll tax credit be less than 100, so that chance of high wage earners paying no healthcare or personal income is low. And at this point, I will just say there hasn't been a number decided upon but what you will see are what it looks like at different percentage options. So I'll stop here for one moment, see if there's any questions just about this concept, and then we'll show some other slides. Okay, let's go on to the next one. All right. I just had to do this. So we're going to go to the next slide. I'm going to let Richard talk about this slide. I warned you all.
This screenshot comes from a brilliant spreadsheet that Charlie Swanson created. And I'll walk you through the parts of it. On the left-hand side of the screen is the adjusted gross income range, going from 30,000 to 500,000. And across the top are the various options that the board will ultimately need to decide on about the amount of employer payroll tax credit applied against the healthcare personal income tax. And the red and the green speak to status quo minus universal health plan cost for employees and individuals. So the idea that the green means that it's status quo minus universal health plan. So if it's green, that means the universal health plan costs less in that column than the status quo. If it's red, that means the universal health plan costs more than the status quo, where status quo could be an employee with employer-sponsored private health insurance where the employee pays some part of the premium and the cost sharing. It could be a self-employed person who is taking Affordable Care Act plan, again, with premiums and with cost sharing. Or it could be a Medicare recipient who is paying Part B premiums and getting a credit against the healthcare personal income tax, because that's a branch that the board already pruned. So we're just dealing with 100% Part B credit against the healthcare personal income tax. So those are the that's what's involved here. Across the top, we're starting with Plan E, and this is for a single exemption. I mean, yes, and the brilliant spreadsheet has four, 1, 2, 3, and 4 exemption. We're just looking at one. And across the top, we have an employer payroll tax with a 60% credit. Then in the second column, a 50% credit. The third column is a 40% credit. Then Plan C is a 30% credit, and then Part D is there's no credit.
And so within each column, then there's 2 subcolumns within each column, and my
Yes,
vision
you
isn't great, but the left is if they're an employee and the right is if they're self-employed.
And so what you see is the difference between the two columns, within the bigger column. Between the employee and the self-employed, and you see that as you have no employer payroll tax credit, that employees pay more.
It's a really great way to explain this. It's really great because, yeah, it totally demonstrates that if we remove that credit, that people are gonna end up paying more.
If you're employed and you have an employer
But
paying,
if you're self-employed, are you
you are not.
You're in the right hand, you're in the right hand column.
so paying more?
Well,
It depends.
it depends. You see all the green areas.
Yeah.
where you're-
Yeah.
Yeah, I
So-
know, so it would harm self-employed people, but help employees.
So first look at red and green and focus where you want to ask about, and then you can go down to the specific, and this is the fabulous part of this spreadsheet, is then you can go down and look at the cells that you're looking at the income level you're looking at, and see, is it read by how much? Is it read by $100? Is it read by $1,000? Is
Those
it
are
read
dollar
by
amounts.
10,000?
Yeah.
Exactly.
And yearly, annual amounts.
This-
These are
yes.
annual amounts.
So divide by 12 if you
So,
think more about.
so the-
it.
in the green, the bigger number is the more savings? or
Yes,
am I
green
correct?
is favorable.
Okay.
That means you would pay
So
less
self,
under you.
so self-employed people are actually getting more benefit, am I reading that right? It's
Oh,
mostly
we're not
benefit.
talking about benefits,
Okay.
we're talking about costs.
I mean, cost, getting more.
So
cost.
green means that under the universal health plan, we still have 5 options, E, A, B, C, and D, that the board ultimately need to make a decision on. But the idea is under those 5 options, the green means under universal health plan, that income level will be paying less than under status quo. Realizing there's a status quo, it means several different things, but that's the amazing aspect of the spreadsheet. It covers that.
I think the thing about the status quo is that Charlie had to assume some basic what people were paying now, because it's all over the board, I think, a bit. But to take something that was and it's a national database, and that's what his little
And
blue thing up there goes and tells you that according to Kaiser Family and the
Yeah.
national whatever, that it's like this
It-
1,200.
is status quo
Annual.
assuming the tax credits through the ACA or that all goes away?
You know what I think would be great is, I think Charlie is here, so I'm gonna ask Charlie to answer that question.
Charlie's here?
Well,
He's on
he's-
the.
okay.
Yes, it does take into account the current credits estimated because they're different for different things. But yes, it makes an attempt to take into account the ACA, both the premium credits and the credits for out of pockets. So yes.
Charlie, can you say, what is the first column to the left of Plan E? What does that represent?
That represents what the employers would pay relative to what they pay now.
Oh,
So all the rest of the columns are related to what do individuals pay, but that first column is what do employers pay in the status quo minus what they would pay in the universal health plan. And this is for the individuals in the AGA brackets on the very left. And so for very low income people, they would pay less than they're paying now. For higher income people, they'd be paying more than they are now.
The employer.
The employer would be, yes.
and so not on this graph is the previous preliminary proposal, which is 100% credit. That's not
Correct.
on.
That is not on here, yes. We do not intend to put that forward anymore.
Will there potentially, depending on what happens, well, I don't. Will there be a version of this? Assuming all the ACA credits are going away?
We'll have to refigure it if the ACA credits go away,
Okay.
because it changes your premium and it changes your
Yep.
cost sharing reduction.
But right now, this reflects the reductions in HR1. It doesn't at all.
No.
Not yet.
No.
Well, so we know those are going away.
Just to add, if that goes away, there will be, the gain from the UHP will be greater, but it will, the cost, well, maybe the cost will be more. So, yeah.
I have the whole spreadsheet.
Yeah.
That I managed to get printed out yesterday, and it is as I waded through it last night, trying to figure it, it is complicated. Because we have, Charlie did estimates of if there was 60% EBT credit, 40, 30, 50, but not 100. And it is, it's complicated.
Yeah.
And individual people, it's really hard to kind of go, oh, here we are. But when he has 2 exemptions, 3 exemptions, 4 exemptions, there's much more than this.
I'd also be curious, if you have any sense of what proportion of Oregon's workers are employed versus, have an employer
Yes.
versus self-employed? Like, what is the proportion of?
Charlie, you take that.
Charlie said that. You told
did?
us that, haven't you, Charlie?
Yes, so, about the vast majority of workers are employed. The numbers of employed workers who are covered by their healthcare plan outnumbers this, well, 86% of those who are employed are covered by their employer plan. Or at least they aren't necessarily covered by, I should say. They're employed by someone who offers a plan. So if they don't take it up, they've made a choice there. And then the number of self-employed is about 20% of the number of employed people in Oregon. So most workers are employed.
Okay, and then there's gonna be a percentage in there who work for small businesses where it's not offered, is that?
Correct. Yes. And so there's other comparisons on that, but if they work for a small business, then their employer is not paying, is not paying now, and for the most part will not pay under the universal health plan for the employer payroll tax. But that's not completely true because there's some larger employers that do not cover now. So yeah, there's complications.
Yeah, well, Charlie, you have your hand up.
Thanks for this spreadsheet. This is great in its complexity. I do think that parity between employed and self-employed is a really important consideration, because I think self-employed people, we all know, are more likely to be uninsured in the status quo because of the double taxation that they face as a self-employed person under Oregon tax law. So on the same income, you pay personal income tax and you pay business tax, and then, it makes it harder to afford health insurance on your own when you're self-employed and in that tax situation. So I do think that even though it's 20% of employed people in Oregon, I think that it's an important consideration. And I just wonder if I'm missing a complexity looking at this. All things being equal, looking at Plan E, that seems to be the plan with the most parity between employed and self-employed under this, under 60%. Am I missing something there? And
No, that's exactly the point, Michelle.
Okay, great. Yeah.
So we've mentioned the word complexity a number of times because it's complicated, but also it's complicated because we have a lot of options still on the table. Between the last meeting and this meeting, we pruned out the credit for Part B. We said we're going to do 100% credit. So the next thing that the board can think about is which of the plans of how much employer payroll tax credit to go forward with. And then, for example, on this slide, if you pick, for example, 60% employer payroll tax credit, you'd eliminate 4 more big columns, and then it starts getting less complex. I'm not telling you what you should do, but part of the complexity is because all the options are still in here, and gradually we're pruning. The other thing is you make a decision and say 60%, and we work through the other decisions that the board needs to make, and there's 4 other big ones. We can always come back and reinstate it. So it's not like saying we can't go back. We can go back because those spreadsheets remain.
Right, and I will just say that is, we're not asking for a number today, so
Right.
I just didn't want to scare anyone. Okay.
So the other, one more thing and then I'll stop. The other four big board options that remain is the family size rate readjustment level. We said it's about $900 to $1,100 for extra person. We can revisit that. We can revisit where it's in income right now. It's roughly 200. It starts at 260% of federal poverty level and goes up to 520% federal poverty level, and then it cuts out. Another decision for the board is the firm threshold level for the employer payroll tax credit. We for these spreadsheets, it's set at 500,000. So if you're running a small company and your payroll is less than 500,000, the employer payroll tax just doesn't apply to you or your employees. Two more things. The healthcare personal income tax rate, Chair Blanc asked me what was. It's around 9%, but we can adjust that to make sure that we raise it up. And then the other thing is the healthcare personal income tax soft cap. Meaning you pay a bunch towards your health insurance, but once you paid on the order of $30,000, then that bump for health insurance goes down at higher incomes because we're paying for healthcare here, not all of the state's expenses. Over. That's it. Thank you.
So I am going to move us along just a little bit, if I may, because I want to get through the end of this and then have people take a look at what we're asking about for in terms of the straw proposal, which is very basic. So if we can go on to the next slide. Sorry, I apologize. I didn't mean to cut you off. So this one actually is something that the committee has a very strong recommendation for, which is that the committee recommends a full credit. So in other words, 100% credit for Medicare Part B premiums paid by an individual. So in other words, that would eliminate the perception that these people would have to pay twice. So this is something the committee felt very strongly about. That's what's built into the
Didn't the
table
board
center shop.
decide that last time?
No,
I
the
thought we
committee.
did.
I misspoke. I'm sorry.
Okay.
It's up for
No,
your.
this is
Okay,
the
Richard said that we had decided. Okay.
I misspoke. I'm
Okay.
sorry.
Thank you. He said committee. So I think that is, and that was very well received, and I think people were very pleased with that. So I'm just gonna, and that one I think is, I'll pause for a second, see if there's any questions about that. Michelle.
My only question is, and this may be a practical consideration, that tax credits are the tool that we have. But I'm just curious if there's any issue with any of these specific populations, like what percentage do we know of people who pay Medicare Part B premiums do not file tax returns and therefore would not be able to get this tax credit?
That is a great question.
Yeah.
Thank you. And I think that that's a really something important to delve into if that's what we're not sure. Yeah, I don't know the answer to that question. So I think if they are not, well, yeah.
If you don't make enough,
Charlie's gonna
If you
say
don't make enough
something.
income,
Charlie.
Yeah, Charlie's gonna say something, or he did have his hand raised to probably answer that.
Yeah, I can say something. So the Part B credit is a non-refundable credit. That's at least that we're proposing, which means that if you do not pay any taxes, if you're not liable for any taxes, you would not have any credit. And so those who do not file a tax form are presumably not filing it because they have no tax liability. They wouldn't get the credit. There would also be a lot of people at low incomes who do not get any of the tax credit either because they also are not liable for any of the new taxes because they're low. They have an income below the threshold for their family level, the federal poverty level. Right now, we're saying 200% of federal poverty level. If you're below that, you don't pay anything. So there are the majority of Medicare beneficiaries would in fact not get the credit because the majority of them wouldn't, even without the credit, would not pay any new taxes.
Thank you. So that for them, nothing changes from the status quo then, is that correct?
Nothing changes as far as their amount of taxes, correct? Yes, but lots changes for other reasons. Yes.
Thank you, Michelle. That's a great question. All right, so go on to the next slide. And then this is very, just talks about the soft cap being under evaluation. So again, there was concern about regressivity with the soft cap and fairness at high income. So what the committee is doing is modeling scenarios both with and without the soft cap, which is again what we talked about, which is a decreasing amount. that would be paid in the healthcare, personal income tax. After a person has paid in a certain amount. And it is a balancing act, goals to weigh revenue and retention concerns against equity and progressivity. So I would say that that's a work in progress. There has been a lot of comment and certainly more comment welcome. And I will go to the next slide. So I don't think we probably want to go over this a whole lot, but this is, so the red and green slide that we put in there, that was the delta, that was the difference. This is actual dollar amounts. All right, so those are two completely different things. But so what you can see is, for example, at what income level a person who is an employed individual, how much they would pay for premium and cost sharing, and then under the status quo, and then you can pop over to the universal health plan contributions side. So again, this is just another way to look at this. And what was really nice is that there are those different examples of people who are either employed, people who are self-employed, or people who are on Medicare. And then you will also see under the universal health plan contributions, you have those different, sorry, because it's such tiny font, employer payroll tax credits, just the different percentages. There's only two on this one, and that is 0 or 40. Those are the only distinctions. So I don't think, unless there's any things that people really want to dive into, sorry, I know my cadence is speeding up. But this is definitely more to look at. And then, all right, so I put this up a little bit. So one option would be, because it was put forth to approve the initial straw proposal, that is put forth on October 16th, that is not recommended by the Finance and Revenue Committee. So I hope no one will be interested in doing that. However, the next, and just, you know, to the risk of being redundant, the Morgan from Echo Northwest and I were talking last night, and he, you know, we've had this discussion about talking how that the per person premium really is reconfigured and built into this household based healthcare personal income tax, and which I think it's a great way to refer to it, is the family size rate readjustment, or FSRR. Because we need more acronyms. But I think that is a really great way to think about it. And again, I mean, before there was really only one healthcare personal income tax, but just there was also then that per person premium. So hence the exclamation points. So for the board to consider it with the per person premium reconfigured to the FSRR, that the employer payroll tax credit be set somewhere below 100%. We don't know where yet, but so more information will come to the board. That the Medicare Part B premium 100% credit be adopted, and that the soft cap still remains for now and is still under evaluation. So, and then, sorry, again, I was rushing through that, but I wanted to make sure that we got to end so the board would have something to kind of discuss or adjust.
So is the committee looking for a direction from the board on any of this, or to just say, yes, seems good, keep working on it, or is that what the committee is looking for? Or
Yes.
do you need any decisions from us today?
Just if the board would approve the initial straw proposal with the following revision. So that's what we're talking about. And again, the proposal, as we've talked several times, just a direction. Or if the board doesn't want to do that and says, no, we don't even want to take a vote on that, we're just going to take a vote on, you know, those 4 bullet points that the direction of the committee, that's fine too. It's up to chair how you'd want to do it. Judy, raise your hand.
I'm ready to make a motion to approve the initial straw proposal with the following revisions as outlined by Director McDonald.
Discussion.
Is there a second? Is there a second?
Second.
Any discussion?
I thought the second thing that you proposed, that we just give you kind of approve directionally the
Yes.
bullet points,
Mhm.
was a better option.
And that's what, I mean, that's what this is.
Okay.
that the PPP is reconfigured. So that graph that we showed, the red and the green. Yeah, yes, that's what's in this second proposal, the revision.
But the board isn't picking any particular employer payroll tax credit rate.
Right. It's just that it's, yes. So that's why this is somewhat deliberate.
So we'll vote on this motion, but my input would be that we consider an alternative motion, that would include the first and second bullet point, so one HCPT of the per person premium incorporated into this rate readjustment. And the fourth one, that the 100% of the Medicare premium is adopted, just those. And that we say, those are the ones that we agree with and adopt as a proposal. And then we request that the committee return to us with recommendations for an EPT credit percentage and examples of different soft caps that we could take a look at, and we'll do those later.
Absolutely.
Okay,
Yes.
so we have a motion and a second, so we'll do a vote on this motion. The motion is currently to improve it with as is initial proposal with all 5 of these following bullet point revisions. We'll do a roll call.
Helen Belanca,
No.
Chenwei Chi is absent, Amy Fellows.
No.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Vicki Richardson,
Yes.
Joe Ramirez is absent, Mary Lou Henrich,
No,
Michael Leahy,
No.
motion fails.
Okay, so would anyone like to approve a second motion that's
So moved.
you stated, Helen, and
Okay.
Michael will.
So the
Yes.
second motion is to improve the initial stall proposal with the following revisions, only one HCPT and the personal per person.
I know, sorry.
Ellen,
It'll go away.
per person premium is gonna be changed to this family size rate readjustment. And 100% of the Medicare Part B premium credit is adopted. That's the extent of the motion, and then a request to the committee that they return to our December meeting with options for an EPT credit and a soft cap.
Yes,
So Mike moved for that motion. Is there a second?
second,
Any discussion? Go ahead, Michelle.
I guess I'm confused as to how this is different. But have no objection. I'm just confused about what the key difference is between this motion and the previous one, but I'm happy to move forward since I think the idea was to bring these things back anyway, but anyway, not opposed.
Right, so the difference is that when we're voting, when we're taking a vote and saying we agree with something, it's to specific provisions of the proposal. So we all are in agreement with those 3, single HCPT and the rate readjustment and the Medicare credit. We're all in agreement with those who are comfortable voting that, yes, we're gonna adopt those as part of the proposal. But there's still so much ambiguity or sort of confusion or it's not really clear
Lack
how
of
the
clarity.
thank you, lack of clarity about how the EPT credit would work or how the soft cap would work. And so we're not comfortable voting on those yet as part of the straw proposal. We just want to pull those out and have folks come back with a separate segment of recommendations. You're right, in effect, it does do the same thing. It sends the committee back to work on those 2 things and bring them forward. But just for sort of clarity and, people aren't comfortable voting on something that they're not sure what they're voting for, because it's not clear what the EPT credit will be. So we're just gonna pull that out until we have more clarity on it.
Thank you, Chair.
Any other discussion? Okay, we can do a roll call vote.
Helen Belanca,
Yes.
Chenwei Chi is absent, Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Joe Ramirez is absent, Mary Lou Henrich,
yes,
Michael Leahy.
Yes.
Thank you, that's everyone.
Great, thank you. Anything further from finance and revenue? Just gotta get in gear, man. You're not doing enough work.
I'm sorry. This guy.
First bounce, so first
Yeah.
bounce on those other things. We'll
Yeah.
come back with second.
and one thing, if people haven't read Echo Northwest's November 14th memo that was posted, it's really very good. It explains things. I think it's hard when we're all talking, et cetera, and trying to wrap our heads around it, but I think that Morgan did a great job, or Terry, or whoever did this, I think Morgan did it, did a very good job. And if you wade through it, you do feel a little better. I underlined it, I mean, on the committee, but still it helped. I
Great.
just want to thank them for that good work.
Yeah, thanks for pointing that out. Great. Do we have a federal and state health policy update?
We do,
It's not.
It's not
but
urgent.
it could also
It's
be
not very-
tabled.
Okay, we can table it till December. Anyone with board outreach announcements? Well, so now with this part of our agenda is going to be changing as of today with the adoption of our new policy that I propose that we include board outreach opportunities in the executive director's report. So everybody just funnel them to Mimi and then she'll include them in her report. But I do want to just, if anybody has future meeting topics, things this board wants to hear more about, more information that you need, any staff presentations that would be helpful. Go ahead, Mimi.
So I have a board outreach, but I used the process and told Mimi about it and I'm using the slides. But tomorrow we'll be giving a presentation, co-presenting, at the Lane and Douglas Regional Health Equity Coalition meeting, along with Les Rogers, who is on the task force. But he's doing kind of a HR1 Medicaid, what's happening, and then I'm just giving a little hope and giving the basic slides about what we're doing and how to learn about our work.
Coming in for the rescue. Great. That's awesome.
And
Great.
mine was just asked yesterday, and so I'm following through the process with Mimi.
Yep.
On Pacific University Health Policy class
That's great.
next week.
Any requests for future topics, discussion, information?
I would be interested in, and maybe Milliman's doing this or whatever, but that question about where in Oregon are physicians employed? Are they in solo, small group, employed by hospital systems? I just think that would be an interesting piece of information to kind of know.
Yeah.
Where it fits exactly,
Mhm.
but maybe with your committee going.
And Cheryl might have that information on mental health providers as well.
Okay.
Clinician employment, yeah. And then small businesses, just kind of the, extent of small businesses in Oregon and
Yes, some just general economic stuff.
right, the proportion, getting more detail about the proportion that currently cover health insurance for their employees and, various levels of payroll tax, at what point the payroll tax kicks in and how many of those businesses that currently don't cover health insurance, how many would be affected by this. I think that's something we got to really pay
Mhm.
attention to. So more information on small businesses. Yeah. Anything else?
We haven't talked for a while, so I'm not sure where it is, and it may have been discussed in committee meetings, but the idea of creating a calculator, which I'm sure all this spreadsheet work is leading to, but just an update
Once we
on
pick the
that.
parameters.
And then also just in looking at all of that complex stuff to add more complexity, there are many employers who offer plans that don't actually cover much. And people, basically have to pay huge deductibles and basically it's like they're uninsured.
Absolutely.
Kind of what do we know about?
Yeah, what do we
Yeah.
know about that and how does that fit
People
into
and
that?
percentages.
Yeah, or underinsured is sometimes. what people
Underinsured,
refer
yeah.
to it.
Oh, Michelle has her hand up.
Okay, go ahead, Michelle.
Thank you, Chair. Wondering if we can request any data on self-employed folks in Oregon and how many of them are currently just not participating because they are priced out. I am worried that is a subpopulation that could be disproportionately impacted depending on how we structure this. And I think it'd be good to have more solid sense of what that impact might be.
Yes, and that number's in motion because I think
Yes,
over the next
because of
year,
that.
it's going to change quite a bit. But yeah, I think that's an incredibly important one.
To add to Michelle's thing, the proposal, and I don't see that it got changed at all from the finance committee, is that any small business or any business that has less than $500,000 payroll will not pay any employer tax kind of thing. So they won't. And some of them that will be a real benefit because they've struggled maybe to be paying for insurance for their people. And
Right.
they will get it, you know, but it's like if we could know more about,
That's my question, is
Your
what,
question,
what,
okay.
what
Well, there's
proportion
small
of small
businesses,
businesses fall in that camp?
Yeah.
And what proportion, I have no idea.
Yes.
Fall above that, above 500,000 and would be subjected, but currently aren't.
Right. And one of the things that we haven't talked, I think it came up maybe in some public testimony or whatever, but I still don't understand how we're dealing with the employers in quote, I'll put the Walmart phenomenon, where their people are really low income,
That they exceed the 500,000,
so they will,
they will
Get hit
pay
with
on
it.
the,
yes,
they will
Okay.
pay on the first dollar
because people have asked
of
me.
all those,
Yeah.
employees.
Okay, and the first, and the 500,000 isn't excluded, or do they pay it starting at 5,000?
They pay for it starting at 500,000.
Okay.
So again, it's avoiding fiscal cliffs.
Yes. Thank you.
Great, do we have anyone signed up for public comment?
Yes,
How many?
6 people.
So is the board okay going over by a few
Yes.
minutes?
Mhm.
Okay, let's give everybody 1 minute, for public testimony.
Can we give them two?
Can we just
every-
say-
Two is
12
12
minutes.
minutes.
Okay, is everybody okay with staying an additional 12 minutes?
Yes.
Yes.
I have to leave, but I can, it's gonna be very tight. We're gonna really try and end on time. I would prefer,
I have a
Do
minute
people that-
too, but this is.
okay.
I yield my time. I don't.
Okay,
5,
so, okay, we have 5 people.
10 minutes.
Go ahead, 10 minutes each and,
2 minutes.
sorry, 2 minutes each and we'll leave it to 10 minutes, yeah.
Yeah, so our first speaker, and Leon, I have you on the list, is Dr. Byrne. So you should be able to unmute now and share your testimony.
Yes, Dr. Vern Sable representing the Oregon Chiropractic Association, and it's relative to not allowing the Oregon Universal Health Plan to discriminate against different provider types as it relates to reimbursement. And that was first came from the Accountable Care Act, Section 2706, adopted into Oregon state law in 2012 via Governor Kitzhaber's CCO bill, which is now found at ORS 414613. It was then inserted into the commercial health insurers in 2015 by way of House Bill 2468. And just recently, this last session, the governor's bill, Senate Bill 822, which applies to large group plans. And the language is specifically relative to not allowing insurers and coordinated care organizations to vary reimbursement rates based on anything but quality or performance measures. In other words, simply put, if I, as a chiropractic physician, provide a certain level of EM code, evaluation and management, you cannot pay me less than a medical physician, osteopathic physician for that same covered service, provided it's within my scope of license to provide. And that, of course, would apply to naturopathic physicians, nurse practitioners, and the like. And so we wanted to bring that forth and to hopefully get the support of the board at some point moving forward so that you have our support. That completes my comments. Thank you.
Thanks, Dr. Sabo.
And Leon, you are next. You should be able to unmute and share your comment now.
All right. Thank you for the opportunity to be a part of this important conversation. So I appreciated that people with disabilities were and their best interests and impacts on the plan were definitely or impacted how they're impacting the plan were discussed in this meeting, and I think that was great. But I'd also like to point in the opposite direction at a way that through some key policy decisions, they can be of mutual benefit to the plan. If this plan can do something that current private health insurance does not do, and it can extend caregiving coverage. So they're called ADLs, activities of daily living. And then there's also incidental activities of daily living that you have a caregiver come in and help with. If they can cover those things for everybody who needs them, regardless of income, you open up a market that I just looked at some BLS 2024 data showed only 22% or 23% of people with disabilities were in the workforce versus about 66% of everybody. We can assume that about 40% of those people with disabilities might want to also be in the workforce, but they're being kept out of it because of enforced poverty. So if we would include them, that would offset some of those expenditures you're talking about. And I think that a lot of these numbers we've seen today would shift quite a bit. And it could actually help make things line up even better for everybody. So that's something I would like the board to consider. I'd like everybody to consider that going forward and maybe work that information into the plan a little bit more. Thank you.
Thanks, Leon.
Thank you. And moving to our in-person participants, Colin Stackhouse.
I'd like to give my comments here just so people that are remote
Thank
can
you.
hear me.
Yes.
Yeah. So hi, I'm Colin Stackhouse. I work with Healthcare for All Oregon, which is a nonprofit that has 40,000 Oregonians supporting the mission towards universal healthcare, specifically in Oregon. So in a lot of ways, I'm speaking for 40,000 patients that you're trying to make a system for. I want to talk about three things, which are unions, town halls, and HCIO's potential role. There's been a lot of comments about how unions need to be reached out to as far as this work. And Helen, I heard you say that the Community Engagement and Communications Committee is going to take part in that work. That group's on hiatus. So that committee is just Amy, Michelle, and Diana Bianco. I don't have a crystal ball, but I can predict that the next time you guys get together, you'll say there's not the capacity to reach out to unions. And so we'll have a check-in January where you tell us there's not the capacity to reach out to unions. In April, we'll learn indeed there was no capacity to talk to unions. So a little frustrating to sort of hear it being passed off to this committee that's not able to work on that. A potential solution is a town hall or any way that the public can engage with this board that is not this meager, rushed 10 minutes at the end of your time together, right? I remember when the board formed a year ago, there was some excitement about some creative ideas, maybe a larger town hall in conjunction with the community engagement group. I remember in May when there was sort of that big brainstorming work group on Mimi's first day, there was a lot of excitement. Oh yeah, excuse me. There was a lot of excitement about a town hall. And so that is, I think, the only way that potentially unions could engage with this work as far as I see. And I'll be real, Oregonians want to talk to you and there's not the opportunity. Mimi, it's great to hear that you're going to be sort of the point of contact for a lot of that communication going forward. I'm excited to work with you and with Healthcare for All Oregon in this field, but there's a difference between what we can create and something that is on public record that's like a governance board town hall. So thank you.
Thanks, Colin.
Yeah.
Thank you. And next I have Mike Huntington.
I'm Michael Huntington, retired radiation oncologist from Corvallis. Again, thank you for the hours of work that you're putting into this. Well, I feel that primary care practices, not insurance companies, should manage care. Efficiency and better outcomes depend on reducing administrative burden and making better use of available resources. Eliminating value-based payment systems would help decrease the unnecessary bureaucracy and perverse incentives. Care coordinators, patient outreach managers, dietary counselors, transporters, specialists, especially in mental health, are vital in keeping patients on treatment plans, preventing unnecessary ER visits, and avoiding preventable hospitalizations. The patient-centered primary care home certification in Oregon requires many of these ancillary services and staffing. Yet in our community, Samaritan Health Services found it necessary to hire a private equity firm to coordinate patient care. That company, Belong Health, is allowed under the ACO REACH program to pocket as much as 25% of the money it receives from Medicare to help Samaritan coordinate its care. However, the collaborative care model for psychiatric care used at the University of Washington simplifies care coordination at low cost. The model shows how expert mental health and psychiatric backup can support primary care and could expand to other specialties. Centralizing resources like care coordination and specialty consults helps primary care practices perform at their capacity, their training, operate sufficiently, cut overhead, boost clinician pay, and improve sustainability. I refer you to James Phelps, MD, and Stephen Kemmel, MD, psychiatrists who very successfully have used the collaborative care model in Oregon and Hawaii, respectively. And I think Dr. Kemmel may have sent a referral in. And I would also be concerned about the Collins point of kind of a silence now about this wonderful work that you're doing. Very few people in Oregon know about it. And then I have comments about audio in the room. I could hear because I've tuned in with my earphones, but I can't hear very well without them. And I think there's ways we can approach that. Thanks.
Thank you. Next, I have Jacqueline Naganuma.
Hi, my name is Jacqueline Naganuma. I'm also with HCAO, but I volunteer. I actually have a whole nother day job in addition to the like 10 to 20 hours a week I put into HCAO. So I'm very passionate about this work is what I'm trying to say. I'd like to second kind of what Colin was talking about the public being able to engage with y'all. I feel like there's a lot of talk about that. You guys are doing this big, heavy lift and you don't feel like you're taking a lot of Oregonians with you. I would agree with that. As a nurse, many nurses, many doctors do not even know this is happening. And that's who's going to be, you know, in the middle of this the most. I would like to testify and ask the board to consider hosting these meetings when working people can attend them. As well as having town halls where they can speak with you. Secondly, so with HCAO, I have been working on putting informational videos together about each committee's work. I'm a nurse. I haven't done anything in politics since last year. Like that's my first introduction into politics. I'm the one that's going to be talking to members about this. Is that who you really want talking to people about it and informing them? Like it would be really great if you're trying to take the public along for the communications and engagement committee to really spearhead that work and put it into a format that really makes sense for people to understand. These meetings are really difficult to understand. I watch them on YouTube, I rewind, I pause, I look stuff up, and then that's how I'm putting these presentations together. So like nobody else is gonna do that. Like I'm insane to do something like that. And it's really hard. And so I just ask that, you know, I hear that the communication and engagement committee doesn't have time, doesn't have the money. Well, you're taking like a 3 or 4 month hiatus now, and you have $144,000 on the table. Please consider using that to pull the public along with you. Thank you.
Thank you.
And Richard.
I'm Richard Gibson. I'm on the Finance and Revenue Committee. My comments are in response to Chair Belanca's question last meeting, which was, what's the universal health plan going to do to control costs? And so the written comments that I submitted have a diagram that show, I pointed out 9 major causes of healthcare cost pressure, which are external to either the status quo or a universal health plan. The universal health plan can address some of them, but not much of most of them. For example, private equity owning physician groups, hospital consolidation, hospitals acquiring physician groups. If we had a uniform fee schedule in Oregon, perhaps that would make Oregon less of a target or an opportunity for private equity to consolidate our physicians. Cost of drugs, pharmacy benefit management system, pharmacy benefit managers dramatically increase the cost of healthcare, and the Oregon legislature is already starting to address that, and that will help both status quo and the single payer plan. We have aging population, which goes on regardless of whether we switch to a universal health plan, but better funding of primary care and rural hospitals and rural healthcare could help aging population optimize their health. Then we have expensive new therapies like gene and cell therapies. I think that the idea there is if everybody in Oregon is covered under the same plan, we can negotiate with pharmaceutical companies about those therapies and get a better price. And also society, with everybody under the same plan, can decide what do we want to spend on healthcare and what do we want to spend on education and transportation and the environment and childcare and other aspects of social justice. And finally, the Universal Health Plan can better fund public health, although that's not specifically in the Universal Health Plan, but that's one of those things that many social factors contribute to an increased cost of care. And if other legislation funds public health, I think we can address some of those. Thank you.
Thanks, Richard.
That's everyone.
Okay, great. We're done. Thank you all. So I think Mike Leahy had our reflection for today.
I'm gonna do, you guys got 1 minute, so I'll get 1 minute, not 5. First of all, I think this was a very interesting meeting. I want to appreciate the members of the general public. I noticed you had a number of good ideas today. So let me just say one thing for everybody to think about that maybe we can discuss either in December or January. That is, I want you to envision it's now 2035. And I want you to now assume in this, you can argue with me, but assume for a second that we're actually successful and we actually get universal health. I want you now to reflect, how did we get there? Okay? I want you to think about that and send me or staff things here, because you need, if you're gonna get someplace, you need to have a clear vision. And I'm just saying, how do you think you'll get there? There's not any one answer to this, but maybe collectively we can come up with the right roadmap. Thanks.
Thanks, Mike. Would anyone like to volunteer to do our reflection for next month?
I think it's been a while since I have.
Great, good. Thanks, Amy. Great. No. And with that, we are adjourned. Thank you all so much for your attendance and participation.
Thank you, everyone.